सिस्टम वाला निडल पंक्चर वेन और आर्टरी दोनों चाहिए.
Yes, of course. I will let the faculty, one or two people log in. Then we can start the program. Good morning. You're muted. You're muted. Anirban, you're muted.
Yeah, can you hear me now?
I can hear you now.
Good.
Good to see you.
Yeah, good to see you and good to see you again.
Yes, and our live case is also on, that you can see it. So let the faculty little bit of, because it's 5:30 a.m. in the morning in America.
Yes, that's what I was thinking.
So we will have some snacks there. We expected some snacks, but some of my friends, they said they will try and join early. So I'm waiting for them. And I didn't call them so far, but I just, shall I call them? Let me call them one by one.
Yeah.
Hi, Dr. Pinto. Good morning. Can you hear me? Can you hear me? You're muted. I think I can't hear you.
Hey, how are you?
All well, all well. Thank you very much, and welcome to this a very exciting session, live case and some lectures. And yeah, so it's 5:30 in the morning in America, in your place, and you are the one who joined. And just now I got a message from the Ashok that he's coming, Kondur is coming in. And then I have a message from other faculty also, they'll take short time to come in.
Okay. I'm just going to go on mute.
But we can start the session, no problem. We can begin the case and start discussing. MS, are you there? Hello, MS? MS? MS, we want to see you once so that we can, discuss with you when to start. He's logged in, he'll come. And as they are prepping up. Yeah, there they are. So MS, can you hear us?
Well,
Yeah, that's great.
so
And we have a Dr. Duane Pinto who's co-moderating the session with me. And he's from Harvard Medical School. He's a chief of interventional cardiology there, and also the professor in Harvard Medical School. He's from BIDMC.
Hello,
And
Dr. Pinto.
Anirban Chowdhury from UK.
Hi, how are you?
So he's also there with
we
us.
don't get a screen here.
Sorry?
No, sorry, please continue.
So we have Dr. Anirban Chowdhury from UK. He's with us. Last time also he was there and he gave a wonderful talks on ISR. And that was so exciting.
All right, we are ready with the case and we have an hour or so to do the case.
1 hour and 30 minutes we have provided you the live time.
Yes. 3.5 with saddle. So
knowing that it's going to be too early in the America, 5:30, we kept that half an hour gap.
3 with side hole. Okay. All right. So we have this lady. It's an exceptional case for coronary thinking as such. She's only 37 years. Sadat is now way. 46-year-old. And when we are doing her angio for effort angina, we have found bilateral stenosis, ostial stenosis. So we have ostial stenosis of left main as well as ostial stenosis of the right coronary artery. She's slightly hypertensive, blood pressure is like 190. Aortoarteritis was also a consideration, but her aortogram is quite okay. And we are now planning to do only the ostium of left main and ostium of right coronary artery.
Okay, and how about the CRP and all other
Negative.
infection marker, inflammation marker?
Dr. Makai? Negative.
Negative. Okay.
Inflammatory markers are negative. She's 46. and no family history of any heart problems.
Hmm.
So Dr. Makre is with me, and we are engaging the left main ostium. Okay, you got side holes on the catheter?
Yeah.
Yes. So he's made side holes on the catheter, or they were already made side holes?
No, they are pre-manufactured,
This is a
heart
EBU catheter with
So while engaging or for diagnostic, did you get the damping of the pressure?
we did,
Yes,
we
yes.
did, we did.
absolutely.
Okay.
There was a,
After every-
there was a ventricularization of the pressure.
Okay, either you
Okay.
talk or I talk.
Okay.
Okay.
Can you show us the diagnostic pictures in the meantime?
Other lab one is there.
They are in the other lab, so
Okay.
we can.
Okay, if possible, you can play it, nothing like it. But otherwise, we'll take a live shot, no problems.
Yeah.
Flash करना.
So, Dr. Pinto, another thing that I come to my mind is familial hypercholesterolemia, which can also produce in early age with the osteal lesions.
Yeah, I
does-
mean, I think perhaps more
Yes.
diffuse disease and atherosclerosis outside of the heart as well. I think
Okay.
osteal disease, I'm thinking radiation treatment as well as aortitis.
Okay.
Correct. Does she have aortic valve disease also? Atherosclerotic aortic?
No. But
Okay.
Dr. Vijay, I feel she's 46-year-old,
Correct.
and the homozygous, they present much.
A homozygous, we are not considering in her case, heterozygous variety.
Homozygous, yes.
Possible.
Yeah.
Pressure.
And have you done the lipid profile? Is there any abnormality?
No. I mean, LDL is about 111. HDL is
Small contrast.
38.
So that rules out the heterozygous variety also. LDL has to be close to 200.
Yes.
Small contrast.
Is she on any statins for a long time?
No. This is only recent story. Just
Okay.
about 1 month,
Okay,
and she's on statin since then.
okay.
Contrast.
Okay. Take a AB picture. Go to full night.
Can you show us the pressure line, please?
Pressure line so far is quite stable. We will
See,
try
because
and
there
show
are-
to you, but it's about 190 to 180 the systolic pressure.
Is she hypertensive also?
Yes, she is hypertensive.
Okay.
Spider.
No renal artery stenosis.
No.
We can see that it's a very tight osteal left main lesion.
Madhav, cutting balloon 3.5. Cutting balloon 3.5.
This looks like it's a 7 or 8 French guide. Is this right?
Go to the
So
10 degree low cranial.
This is 7 French EBU. 7 or 8?
7.
7.
You know, with the osteal left main, you're
Yes.
not obligated to a 7 French system. I tend to be a radial operator, so I would treat this from the right radial approach because I'm short. Also, I don't like reaching over people.
Dr.
Have you done
Babu,
any?
3.5.
Have you done any imaging on this IVUS or anything?
No, we will be doing it now.
Okay.
I was problem.
get me the wire.
3, 5, 10. And I was probe. Yeah. Regular wire.
Intermediate.
Height of
Yes,
propagation.
I guess, imaging it before you do any ballooning would be helpful. Because if there was any angle issues,
Regular wire,
BMW.
you probably will have that information because once you balloon, it's no longer the same.
Can you increase your volume? The volume is low. Dr. Anirban. Volume is a little low.
Ready the IVS.
Is this any better?
Much better.
Yes.
Much better.
So what I was thinking is imaging it upfront would be preferable than ballooning and imaging.
Yeah, that's what he's starting with, the imaging only.
Oh, yeah, I mean, generally, whenever we talk of imaging, we talk of IVS or OCT. And I think our current thinking is OCT gives a lot better images compared to IVS. But since
absolutely, unless you have high definition IVS, they say that is also pretty good. What is your take, Dr. Pinto and Dr. Anirban?
Well, I think you're right. Obviously, OCT is cutting resolution and imaging. With an osteostenosis like this, though, that's very tight, you're not going to opacify very well, and you're going to have a lot of blood. So my preference in the left main position is high definition IVS.
Correct. These days it's available in India also easily. Otherwise, company can provide us
go to this
temporarily. Dr. Kondur, any comments from you?
No, I agree with Dr. Pinto. Morning, Dr. Pinto. Because of the tight osteal stenosis, very hard to pass the OCT. So I agree with Dr. Pinto. High definition IVS.
Yeah, it has a lower profile.
Lower profile, 1.8 millimeters. So easily.
Yeah, and it's 5 French compatible.
Epicranial.
Correct? Am I right?
Correct. Very low profile, 1.8. Sometimes if you're not able to pass 1.5 balloon, very hard to pass on high definition IVS. So this, in this case, can be done.
Yeah, 5 French compatible. We have used this high definition IVS here in India.
Give me that view.
And the catheter is really a remarkable improvement in the catheter.
I mean, all your IVS catheters are now 5 French compatible.
Yes.
Eagle Eye is the oldest and the bulkiest. Even that is 5 French compatible. You can't take a second wire in a 5 French with the Eagle Eye. But even so, all of them are, in fact, I guess when you are doing left main, you know, OCT is more for, you know, luminal definition, etc., etc. But left main, you're looking at calcium vessel size. That's what you're essentially getting. So I guess IVS is
ready.
Yes.
But
let me
OCT get very
let
good.
me introduce our live case operators, Dr. M.S. Hiramet. He is a huge volume operator, highly skilled interventional cardiologist, and very experienced. He has variety of left cases, restenosis, ISR, and he has innovated several techniques by himself while doing the procedure. He improvises. It's great to watch him as an operator, and Dr. Maclay, of course, with him for a long time. And both of them work together, and they have a huge experience. Volume is very big. It's one of the prime center of the Pune city, which is we call a metro city only, but it's a second level metro, second tier metro city. So it's almost about 175 kilometers away from Mumbai. Okay. And in terms of mile, I must be talking for American crowd. I mean, faculty that.
Don't worry, that's where my dad was born.
Yeah, so it's very close by. It's close to about, you can say, 110 miles or so. So he's regularly doing live cases in India and abroad. And he has been an ex-president of the Cardiological Society of India.
Thank you, Vijay, for that introduction. I'm sure there are many people who are more experienced. Many centers.
But we have to introduce our own faculty at this stage and let everybody know who's what. Even Dr. Ashok Kundur, I have not introduced him as yet. He's a great friend and he's a very large volume operator. Particularly, he is into these cheap CTO cases. He looks into the very complex angioplasties at his center, Beaumont. It's in
So
Michigan.
I work at Ascension Health now.
You work at Ascension Health. So it's a part, I was thinking it's a part of Beaumont?
No, it's a different system and
Different system, okay.
different system. Yeah.
Okay, okay. I was under that impression, so sorry for that.
Thank you. Yeah.
No.
Thank you, Dr. Mon.
So,
Ostial left main, that is what we are discussing.
yes, correct.
So between OCT and IVUS, anybody has any particular preference? Our choice today is IVUS because I feel injecting contrast with an ostial lesion is always very tough and you never get very good images with OCT. So we have taken IVUS today.
Absolutely right decision. Is it high definition, IVUS?
No, it's a Volcano.
Volcano, but they can provide us with the high definition. There is a console which has a high definition catheter intake, and it can give, that's what we are doing in our Lilavati Hospital, Mumbai.
No, in fact, we have a regular IVUS.
Okay,
And
40 hertz.
there was some
Boston
emergency in some
Boston
other,
Scientific also. but
Boston Scientific, yeah.
there was some emergency somewhere else and they were desperately looking for IVUS. So
Okay.
we have given it to them and we are with this particular IVUS.
Okay. That's good. No problem. 40 hertz is
Good
fine. These
deal,
are big
a good
vessels.
deal, of course. But I don't know, we are not really very familiar with this particular IVUS. You're okay at the
So-
back end?
Yeah, yeah.
Correct. So we have only
Where
ostial
can we
left main.
see?
The rest of the cardiacs are normal.
Sorry?
We have only left. And rest epicardiacs,
Yes.
they are all normal.
The normal have
Correct.
ostium.
Not calcified. Doesn't look like they calcified.
No, not at all.
Had they calcified, then what would have been your approach?
Bring down the
Or calcified, actually we will see better with IVUS, how much is the
Correct,
calcified.
correct. But had this been a calcified,
Yeah. Okay,
that's
we can
what
go.
we've been trying to discuss with
You're
you.
seeing it here.
Yeah.
Yeah,
So
very tight.
Well, I don't know whether you all saw too much, but pressure is not damped. We have a side hole, of course,
No, naturally.
and then we are
Only
trying to
thing with
withdraw.
the side hole, you always will have a challenge to place the stent properly. So that we have faced, I don't know what is experience with others. Ostial left main, do you use side holes? Dr. Pinto, Dr. Anirban Chowdhury, Dr. Kodur.
Okay.
No, we don't use side holes. It's so misleading.
Correct. Correct. I also don't use the side hole
No,
catheter. but-
this lady, when we did a diagnostic
Actually, being side
angio,
hole catheters are dangerous.
she had very bad angio experience because every time we engaged, she used to drop
Pressure damping was huge.
Yes, and
She was getting angina severe.
severe
Oh.
angina. So
Okay.
that's why
I still think even when there's side holes and people are getting damping, the best thing to do is just back out the guy. And I use a smaller system. You don't need a 7 French system.
Yeah.
And you don't need an EBU catheter either. You can use a JL4.
Yeah, I think one of the big issues is if you continue with the side holes, you'll end up using a lot of contrast. You won't be able to see things well.
Take a second run.
Yes.
So is it possible?
He is a great internationalist, our Dr. MS Heramat. there must have been some challenges using non-side hole catheter. I'm sure there must have been some challenges.
No, the diagnostic angio was done with no side holes. And the operator had tremendous problem getting images. I was also told that patient had near cardiac arrest during diagnostic angiogram.
Okay.
So we preferred bring her in with
yeah, must
side
have
hole.
been pretty challenging without side hole.
Play.
We are playing the
Play
image
the second one.
of the IVUS.
Can you see it on screen?
We have one question, Dr. Hiramat.
Yes.
Why did you use 7 French? 6 French would have been good enough.
No, I mean, if you have to take in the imaging catheters, it's much easier taking 7.
You have the old system of catheter, so it's better. Friction is less. Artifacts are less.
Yeah,
Calcium there and narrowing.
just tell him where to freeze.
Hey, stop and forward. We are in guide catheter. Go further. Go up.
Go in.
Go inside.
Can you show us one side fluoro also so that we can see where the catheter is?
Oh, no, I mean, we have withdrawn. We are now showing you the
Correct.
IVUS images.
All right.
So it's a fibrofatty there.
Yes.
Yeah. Okay.
And looks like eccentric mainly.
Yeah, yes, and very eccentric. And I don't think there is any calcium as such, you know.
I think your first run probably was a better quality.
Show the first one.
First run had a better image. I also thought so.
Show the first one. See, first one was obtained from
So
the
we have
proximal
Dr. Sripal Bangalore from New York University, Langon, and he is a very well-known name in the field of interventional cardiologist, and he doesn't require any introduction. He's presently featuring also in the AUC of 2021. So as one of the panelists or the member of the AUC committee.
Cutting balloon.
And he's well known in terms of research, his phenomenal sense of presenting data and phenomenal interventional cardiologist, very well known across.
Okay, can we have the opinion from the faculties on this IVUS?
Yeah,
I mean,
sure.
It is a short run. Okay.
Yeah, we didn't see where the angiography, so we don't know where you started from the images that I can see. The disease seems to be probably in the body or the distal left main, wherever. I don't see anything convincing from the images that you have in ostial LAD, ostial left main. There's a funny takeoff. It might be an angle issue of pressure damping. But when you come close to the guide, this I would have thought is the body rather than the ostium of the left main. But we didn't see where your imaging started from. But close to your guide, we didn't see any major calcium or atheroma.
Imaging started from the proximal LAD, coming up to the guide catheter.
Okay, so this is, where do you think, is this the left main or is it?
It's a left ostium. Yeah.
Yes, this is the left main ostium.
Okay. So, you know, what I was thinking that had we had the co-registration, then would have been easier for the viewers to identify where your catheter is.
Actually, as I told you,
I know the system is not there. You told us that it had to go somewhere else.
Measure the inside.
Atla inner diameter. Any inner diameter. Atla diameter. Okay.
Sripal, any points that you would like to make? This is a young lady of 46 years old and presented with significant angina and found to have a left main ostial disease and right coronary ostial disease. She does not have any aortoarthritis picture.
NC.
CRP, everything is normal.
NC 4.
And there is no heterozygous hypercholesterolemia. So only ostial lesion in the left main and the RCA.
Yeah, no, definitely. It looks, in a way, it's a very interesting presentation. I mean, one of the consideration is, did she receive any radiation to her chest? And
Yes.
why does she have
Any history of
osteal involvement?
radiation, MS?
No, no, no. Huh?
No.
Nothing. She's an average lady, and she has 2 issues: no hypertension during pregnancy, and no known risk factors. Family history also is not positive.
So your area coming to 5.8, and which is not cutoff point. I think cutoff point is 5.35. What is accepted, Dr. Sripal? Bangalore?
You know, typically anything less than 6, but again, it depends. So, you know, although we use absolute MLA cutoffs, I mean, depends on the body size and percent plaque composition, etc. But I mean, typically anything less than 6 is significant.
Okay.
Just
Because
run it once more.
You know, other day I was reading that if you have it depends on the geography wise.
So the fluoroscopy.
So in America, the artery sizes are big.
Yeah.
So geographically, 6 MLA may be a little too much for cutoff, and maybe we need a little lower figure. Whereas in India, we see usually about 4 millimeter left main. So MLA of 6 and less than 6 cutoff should be good enough. Am I right?
Yeah, no, exactly. I mean, you know, so the MLA, since we are using absolute cutoffs, I mean, in a way, it doesn't make sense for all patients and body types and what's your reference artery diameter.
So what are you trying, Dr. Ahmed? Have you taken the balloon?
This is a cutting balloon, yes.
Cutting balloon, yeah. I can see that your balloon showed waist. Am I right?
Yes, yes. 1 minute. We are just doing the guide catheter. Okay, let's go.
Yeah, you disengage the guiding catheter so that, yeah. This is
3.5 NC. This is 3.5 cutting balloon.
Cutting balloon, okay.
So by cutting balloon, you mean Wolverine, something like that?
Oh, Wolverine.
It is a score flex.
The score flex. Okay.
Acha.
Give me a 4 NC. 4 NC.
So let's talk about the scoring balloon versus the cutting balloon in a left main situation. What is your, can have all the panelists give opinion about this so that we enlighten the audience about this?
Well, in general, if you have an aorto-osteal disease, it's the disease of the aorta. I guess that's the reason all the discussion came up with radiation and hyperlipidemia, etc. So it's not necessarily a disease of the coronaries itself, and these will be quite fibrous or plus minus calcific. So if you see an osteal disease, I think it's unless you have very strong evidence otherwise, it's not a bad idea to score it or cut it, whatever you feel comfortable with. If it's a very rare situation, you find it's all soft atheroma going from the ostium to the body, you can decide otherwise. That's probably my personal.
Exam cycle टाकला आतापर्यंत जो बदला discussion चालू आहे.
Run it.
Yeah, it's looking better now.
No, these are the primary images which we are just showing you. Can you see that?
No, you show in this view. This view is good view to understand. Have you pulled back the catheter here?
No. Do you want us to work in that view?
Yeah, that will be better. So that we know exactly our cutting balloon is.
0.5 Medtronic stent. 8.
And geographically, it looks you have disease in the distal part of the left main as well. And that might have been the soft plaque that you saw on IVUS. And the left main on IVUS was only a 4 millimeter vessel, but your circ itself probably looks as a similar size. So this might be one of those where your parent vessel doesn't follow the rule of 2/3 of your daughter vessels if you follow the imaging findings.
You're ready to inflate?
How often that happens? Any idea?
Yes, sir.
Don't know, but I've been surprised a few times.
No, yes.
Especially where
Even we get this kind of thing that daughter vessels look bigger than the left main.
I guess you have to make sure there isn't spasm. That's crucial.
That's another thing that we have to, of course, look for.
Okay, let's go. Going up.
But we don't see much, but we see rarely these kind of cases. The daughter vessels are looking bigger than the left main.
8, 10, 12. This is 4.5 NC balloon, and we are going to a pressure of 14.
Okay.
Okay, deflate.
So Dr. Pinto and Dr. Chaudhary, so using a scoring balloon in the aortoosteal lesions, do you think any cusp dissection risk is there because of the longitudinal incisions created by scoring balloons?
I haven't had one yet, touch wood, but I can see what you're trying to say.
And
What
to
can happen.
4.5.
The Scoreflex is
12.
it's a pretty soft balloon, I would say.
4.5.
Even if you take the non-compliant Scoreflex, there's only 2 wires. I think the risk is probably much lower. But
risk will be higher in case the osteal plaque is extending into the aorta. And that is a possibility in aortoosteal lesion.
Yes, I guess then if you inject, that it can cause it. Yes.
Yeah.
I think that's the key is, I mean, like all of us, we routinely go well past the nominal for the cutting balloons. You know, I don't know of anybody that goes to 8 atmospheres, 9 atmospheres.
4.5.
At this stage, I had a case where I took the patient for soft plaque in the left main, young patient about 34 years old. And the moment I engaged the catheter, I had a dissection, retrograde dissection into the aorta. And there was a diastening, hugely. So in those circumstances, either we stent or we hold back and send the patient for surgery. These are the 2 options that we followed, and we sent that patient for surgery.
Was the dissection from a cutting balloon, or was the dissection?
No, it was just guiding catheter causing the dissection.
Yeah, so that's a different question. So
yeah,
if we're talking about aortoosteal calcified,
natural. It's a different. I was talking about the retrograde dissection into aorta that can happen from the left main guiding also. That's what I wanted to make a point of.
Contrast. 1 minute. So now let's discuss what are the views for osteal positioning. Let's go to spider and LAO 3030. First spider.
And epicranial also? Do you use epicranial in your practice?
Yeah, we used to use epicranial, but then subsequently a lot of discussion and stents are used in LAO 3030.
I think this should be done by IVUS. So you can mark the ostium and then you don't have to guess. Then it doesn't matter which view you use.
Oh, that's a good idea, actually.
If you're doing a left main PCI, the IVUS not only lets you size the stents, but it allows you to mark the ostium without fault.
Can we try that? MS?
I don't know. We have never done it, but if you tell us, we could try.
Yeah, I think so. We should try. Worth it, because it's something new which we can, demonstrate that identifying ostium is very important when you are stenting left main ostium.
Only the ostium. Besides, in this case, only the ostium.
Yes.
Ready?
Yeah, I think the potential options are, you can IVUS mark it, but more recently, I tend to use a bumper wire technique, and that tends to be very accurate in all. I mean, now my routine is a bumper wire technique for any osteal lesions. And
can you describe a little bit about bumper wire technique?
Yeah, so you take a second wire and you put it in the aortic cusp. And so that's your first step, and then you advance your stent into your left main and you advance your guide at the same time. So the guide will be restricted by the bumper wire. It won't go in beyond the ostium. So and based on the position of those two, you can accurately land that. But I agree with some of the comments here that the left main is smaller than the either of the daughter vessels. So I suspect that either spasm or more likely diffuse disease. So I think that's why it needs a strategy.
Yeah,
I mean,
possible.
I also tend to be go err on the side of safety. I would have put a second wire in the circumflex just in case. I mean, you never know. Sometimes there may be dissections, etc. Just to be safe, to put in a second wire in the circumflex.
I mean, I think biologically the left main should not be smaller than the circumflex of the LAD. So it has to be either plaque or spasm. And so if you think that both of those can be rectified by the use of IVUS.
Correct.
Do you want me to go ahead?
Yeah. So we are ready to go up.
Balloon will be changed. One patient.
MS, any idea that do you want to do IVUS or you just want to stent right away?
No, we have not done that. So unless you want us to do it as a first time, we could do it for you.
No, but what do
Yeah,
you
that will be nice. You know, if you can, if patient is comfortable and not having angina, then we can try it.
So you
So
do mean to
what
say
are the
that we
steps?
put,
We put one more wire and IVUS on that?
One more wire and I was on that. And
what will happen when we inflate?
no, the IVUS, the wire and the IVUS catheter has to come out.
what's the advantage?
No, why are we doing it? You know, I mean, to know whether we are ostially well placed.
Yes, that's the only
But while we are removing the IVUS, again the stent will either prolapse in or it can come proximally. It may not remain constant there.
Okay, we are going up with the inflation. We just give one more contrast and we go up. Wait a minute. Okay, go contrast.
You're convinced that you're a little bit 1 or 2 millimeter out of the ostium of the
Yes. Okay, go.
left main.
दोनों लोग हम तो तुम्हें गाइड करते रिलीज करें.
So our catheter is at 2.0. I have freed the catheter. Save that. Okay. Don't go too high. Okay, this way. So this is a
Yeah,
4.5.
you can talk about the osteo flash balloon while we're getting set up there, huh?
Come to RAO caudal, please.
What point, Dr. Pinto, what point do you want to make, John?
I was just asking Ziad or Sripal to talk about the osteo flash balloon.
Yeah, so OsteoFlash is a device with two balloons. It's got a long balloon similar to a coronary balloon at the end of it, and more proximally, it's got a balloon in the shape of a ball.
15, 16.
And they're inflated separately, but they're attached. So what that does is there are four markers on the balloon,
18.
and if you line up the middle two markers to the edge of the stent and inflate, you then inflate the OsteoFlash balloon, which is a ball afterwards, and it flares the ostium for you. The problem has been that the OsteoFlash balloon, the plastic that's made to use the balloon is quite a bit thicker, so it's been difficult to get out of a 6-French guide. They've actually just redone the entire program and coming up with a new balloon, a Gen 2 balloon, in the next several months.
Very good contrast.
Welcome, Dr. Ziad Ali. Nice.
Thank you.
Nice. Can we see your video for a while, just for a while?
Not unless you want to see my commute to work.
So your comments is right in the beginning. I think it's
Ziad works much harder than I do. I'm still at home.
Absolutely. He works much more harder, and I would like to tell you a few more things about Dr. Ziad Ali. That he's excellent interventionalist in addition to intravascular imaging. And he does about 100 CTOs in a year.
Not working.
That was a news to me. And also the...
No, don't pull the wire out.
I'm not pulling the wire out.
I come to RAO caudal.
And of course, the complex angioplastic cases in addition to structural heart. So it's, I think, quite variety of things.
4.5.
I must say, the technique described by Sripal, I didn't realize it had a name, because that's we have been using this wire in the coronary sinus for a long time, and I tried to modify it by pushing the guide till you see a little bit of kinking of that wire which is in the sinus. And I thought it was my own iteration. Now it's sad to know that there's already a name attached to it. But I find, especially the left mains at times, it's especially the right osteums at times can be much more difficult to visualize compared to the left main. Left main, most of the time, one of the LAO cranes or PA cranes gives you a pretty
4.5 by 8.
good, especially in the right, where it's a posterior origin, and it's very hard to visualize. I think that wire technique, it really helps. It really helps.
Shripal, I didn't know that that is a bumper wire technique. We used to use a floating wire technique in sinus or osteopro, been particularly dealing in the RCL, osteal lesions. Now we have a name for it.
Yeah, it's really very good, and specifically like when you IVUS or image after, you'll see that you may be just one strut out, like you will be very accurate. I mean, it's one more in addition to everything else. You can IVUS mark it, bumper wire, use a couple of views, and because the last thing you want to do in an osteal lesion is to miss the osteal.
Stent is what?
So,
12.
I would say one of the most
And this is where to keep it
recently
loud.
described techniques is actually where people inflate the balloon while holding it outside the body and thread the wire into the distalmost frame cell of the stent. So you actually advance the wires together and the stent over both wires, and then the stent will get stuck on the last frame, so you'll only have one cell outside of the left main. But these all require a little bit of faith. And the reason I like intravascular imaging is it doesn't require faith. You're literally seeing exactly where you are. You're marking the aorta, and so you can put your stent optimally placed. If you use an 8 French guide, you can actually put both devices in at the same time. You can have your IVUS immediately adjacent to the stent, as long as you don't have a volcano IVUS. It has to be either Boston or Refinity. It could be a volcano. It just can't be a phased array.
This Sabo technique that Riyad is mentioning. I think it's never a good idea to dislodge the stent from the stent delivery balloon before putting it in the body. And I think there are just so much easier ways to deal with this.
Yeah,
so I think the Sabo technique is one of those ones that everybody talks about, but I bet none of us have done it.
Yeah, I would be very careful. I mean, to do anything outside. I mean, the last thing you want is a dislodged stent.
I did try it a few times and it went okay. But in one of the Euro PCI conferences, one of the panelists said, by the way, Dr. Jabo doesn't do it himself anymore. So once I was informed that I've stopped. Can you take me through this IVUS? I have done this for osteal LADs, placing the IVUS in a circ to know exactly where my ostium of the LAD is. But the ostium of the left main stem, you're not saying we keep the IVUS in the left main and inflate the stent in the left main. You're trapping the IVUS there.
No, so this is actually very simple. So you take the IVUS on live until you see the ostium of the left main and the aorta in the same picture, right? So you'll see a big hole on the IVUS. And then you just put your foot on the pedal and cine it. So cine that spot, and then do not move the table, have your stent ready. And then you take a marker from one of your nurses and you put the marker onto the screen and you advance the proximal dot of your stent to the dot on the screen and you inflate. That's it. As long as the patient doesn't move over those 30 seconds of you implanting the stent, it's almost fail-safe. I mean, this is the routine technique we use now for all osteal stenting.
That's great. I mean, that sounds a bit similar to a good technique. How we do the osteal.
Have you named it?
Very easy.
What I'm trying to say, this is very similar to how I do the IVUS guided cap puncture. I do not necessarily look at the IVUS. I find it quite hard. I do it entirely angiographically with projections with the IVUS in place. So this sounds very similar to what you're describing, except, you basically, as long as you have the same angle, the patient hasn't moved and it's on the screen, and that's how you do it.
If you have an 8 French guide and you have a 5 French or 6 French rotational IVUS, you can actually put the stent and the IVUS immediately next to each other. And then you advance them together until the IVUS sees the ostium of the left main and you can see the aorta. And then you just pull your IVUS back a few millimeters and inflate your stent.
Okay, that's a good idea.
That also, you have to, so we typically would do that in a CTO because we have an 8 French guide.
But you need an 8 French guide for that.
Yeah, with a 7 French guide, you can do it with a 5 French Boston IVUS and a stent. But the problem is it gets pretty tight, and that can be uncomfortable. So that's not a beginner move.
Correct. MS, can you tell us what is happening?
Oh, we did stent was 4.5, 12. This was a Medtronic stent. And then we are post-dilating. We dilated with a 5 NC balloon. The back end towards the aortic ostium, we went up to about 20. And distality of the stent, we went to about 8. And this is what we are seeing.
But due to those side holes, a lot of dye is going into sinus.
Yes.
We are unable to appreciate the ostium.
Ileocranial. We'll go ileocranial and see if we see something better than this.
Is there any plaque shift to LED? A lot of haziness there.
Yeah.
Go beyond.
Do you think there is something happening in the LED ostium?
No, so far patient is comfortable. EC is very good, very stable. Heart rate is same.
Yeah, this.
And you recall the previous image where the orientation of the vessel was superior. So that
view.
Run number, yeah, 5. Play this.
Go to run number 2 view.
15, so with the stent, it has become a straight.
Yeah.
Yes.
It looks like there is a diffuse disease in the left main. And there was a plaque also in the left main. You could see that on IVUS. Am I right? Did you appreciate a plaque in the left main?
Left main only towards the ostium.
Towards the ostium, yes.
I think we have a lot of contrast going out from the side holes.
So can you exchange now to a different without side hole catheter?
My worry is the lot of, some part of the stent is projecting into the aorta and the subsequent catheters may not be able to engage.
Yeah, so there are a couple of tricks you can do. One is to use a guide extension catheter. So with the guide extension, you can actually close those holes of the side hole, and so it'll convert it back into a non-side hole catheter.
Why not track? It's a good idea. MS?
The telescope. Telescope or guide.
But you will require a 7 French.
6 French.
We are with 7 French.
Yeah.
6 French.
Yes. So we take Guidezilla.
Okay.
Yeah. My only thought is you probably are better off having a having a balloon in front of your guide extension. Otherwise, you might mangle this stent. So have a put a Guidezilla in or whatever you wish to. Take a balloon, put the balloon into the coronary first, and then walk the guide extension.
Yeah, so correct. But then it will track in the lumen properly. Aligned in the lumen.
With this technique, you really don't have to come out of the guide. The main intent is to close those holes in the guide.
Correct. So you don't have to come out the guide.
2.5 से बोलते हैं 2.5 से बोलते हैं
So what stent did we deploy? Is it a 4 millimeter stent? Was it a?
No, this was a 4.5 Medtronic stent.
And the length was?
12.
12, okay.
बोलो जरा 2.5 से
So we recently have a stent in the United States made by Boston Scientific called a Megatron stent. The stent is meant for the left main in that it has reinforced or this geometry of the stent struts
Higher radial strength.
is meant to give higher radial strength.
Correct.
So we've been using this in the in large osteal vessels.
Correct.
So
Especially when
Dwayne,
you
we don't have the Megatron. So let me ask you something. So when you're stenting across, let's say you've got a prox LAD lesion and you're going to stent across, will you use a Megatron there?
Yeah,
Okay.
I haven't had any
And-
problems recrossing into side branches or any of that stuff.
It's still an open cell design, right?
Yeah, I don't honestly know, Ziad. I know that it's a version of the Synergy stent, but the strut, composition is slightly different. But having used it in a number of left mains, I haven't had any problems. Both doing DK and culotte.
So is there any study of follow-up angiography on Megatron in left main?
Looking for late loss or looking?
Yeah, because it was expected that it will provide, it will give more trauma to the vessel and restenosis rate may be a little higher.
Hello.
Yeah, I don't honestly know what was the approval process. Whether it was safety and or whether it was an efficacy endpoint.
Yeah, I mean, I it's interesting because Sripal's here. He wrote a excellent meta-analysis versus. So
this is a good idea, actually. Excellent idea.
Megatron has 92 micron strut thickness. Its metal to artery ratio is 15 to 18%. And we sort of moved away from that direction of thicker struts, increasing metal to artery ratio. So Boston has basically reversed the engineering to a certain extent to allow a 3.5 platform
directly to the tip
go
of
to a
the
5.75 platform. It would be interesting to see how vessel healing does with the thicker struts and increased metal to artery ratio. But it probably has the highest radial strength, as Dr. Pinto has mentioned. That's been the selling point in heavily fibrocalcific lesions.
Okay, we can give the contrast.
I think a more important factor in deference to Sripal.
Yeah, this is better. This is a lot better. We
not,
can appreciate
the
this.
strut thickness, but rather luminary.
MS, this is a lot better.
Yes,
Picture.
I think, yes, a lot better.
Yes.
It is an NFEST, that's the only thing.
Go a little bit low.
You can still take it you can still take it in the your guidezilla, take it in the guiding.
No. The balloon has shifted. The wire and balloon has shifted.
Now this is better. This is better. Just close the side hole. That's the only thing that is.
Watch your wire there. It's going to start coming back in a second.
Yeah, that's better. That's better.
No, we are in the way.
I was going to make the point that in the left main position, the area you end up with the stent is probably just as important.
Wire has come out.
Wire came out. Wire is out.
Yeah, that's what was going to happen.
TP. Ready with contrast. This is contrast.
Yeah.
Huh?
Yeah.
We can, without wire, we can make one shoot so that we get a good idea about.
If this happens to me, my next step is to take a diagnostic catheter. So you don't want to mangle the struts of the left main. So in Excel, we found that if you 6% of patients had a mangled strut, and their target vessel failure is 2.5-fold higher. So we need a lot of careful quality movement of the guide at the ostium of the left main after stenting.
Diagnostic catheter is 3.5. Diagnostic.
Yeah, and I think Ziad's point is well taken, and I think that also emphasizes why part is the first thing to do. As
Correct.
soon as you deploy a stent, so you kind of tack up your proximal and ostial part of the stents.
That he has done. I think he has done that. MS, you already done the ostial high pressure inflation?
Yes, yes.
In the catheter, be careful.
So you think already the ostial part of the stent is flared up with the
Yes.
high pressure valve? Okay.
Sheet पकड़ो क्या? Sheet पकड़ना.
I think this is one of the perils of using the angiogram. The stent is sticking out now, and so then that's really where the imaging helps. So I understand there are economic constraints, etc. But if there's one place you're going to use IVUS, it's got to be the left main.
Absolutely. He used the IVUS here, but it was 40 megahertz IVUS. That is not high definition IVUS because that machine is though available, but it was not
plenty.
available in this cath lab at this stage.
40 megahertz is plenty of megahertz.
Yeah, I know.
Mark the
I know what you mean. Correct. You're absolutely right. He used that 40 megahertz, and we saw the images. We'll show you the images also.
Sure.
Yeah, I mean, I had never used.
I'm sorry, I must have missed that part.
Yeah, but we'll show you that images. MS, Ziad want to see images, IVUS images. So later, please.
Just show IVUS images.
If we have Ziad here to comment on IVUS images, we are very happy to have him.
So this is 20 megahertz IVUS, which is also fine, right? So the key points to using 20 megahertz IVUS are it allows you to size the vessel, right? So you should find it, and you need to go slowly because the IVUS jumps.
No, you can't. We can do the fluorotransplant later.
So yeah, good. So this is all plaque. There's no spasm here, right?
Correct. This is all plaque, an eccentric plaque, basically.
Yeah. So even the left main, it's got atherosclerosis in it. I think they would have to pause it near the ostium if they to really get a good understanding.
But what could be the mechanism? What could be the mechanism of ostial atherosclerotic disease in a patient who does not have aortoarthritis and the lipid profile is normal, does not have any heterozygous familial hypercholesterolemia? Any other condition which can cause like this? Only ostial lesion in RCA and ostial lesion in the left main?
Well, I guess, fibromuscular dysplasia would be right at the top of that list.
Correct.
And I have to say that in fairness to the previous comments, I stand corrected that the left main is actually small.
Very small.
It's very small, even on IVUS, and that's very unusual.
Very unusual. Looks like diffuse narrowing of the or spasm maybe of the IVUS of the left main.
Yeah, unfortunately, that's very difficult to make that diagnosis with the IVUS.
Correct.
Unless you give nitroglycerin at the same time and see the vasodilation. But
correct, because what we saw angiographically was the circ was looking bigger than the left main. So possibility of left main in spasm is something which should be kept in mind.
We have been discussing OCT and high definition, but I hadn't used Eagle Eye till about 9 months back, and it offers a lot of advantages, especially in large vessels where you're essentially looking at vessel size calcification. You're not looking at minutiae in the lumen. It allows you to do the manual pullback, which is usually the normal. You can pause, as Ziad was saying. You can push it back. And Philips has the technology of core-edge without any thinning. So it has a lot of advantages, and especially in large calcific vessels. I think it has, it's quite a good tool despite being 20 megahertz.
Yes.
No saddle.
Huh?
Saddle or without saddle? We want to
No
do the
saddle.
I mean, I think the major advantage to 20 megahertz IVUS is that it's extremely fast. You just plug it in and use it. So for cath lab workflow, that is the predominant advantage, in my opinion. Also, of course, as you mentioned, the co-registration feature, if you have it, can be quite nice. Although what's interesting for the left main for Sync Vision co-registration is it's much harder to co-register in the apicaudal and areocaudal views than it is in the cranial views for some reason.
Yeah, that's a good point. Because we faced these difficulties a couple of times. We have a co-registration IVUS available. And we faced this problem, and now we'll try it in the AP view. We've not tried it in the AP view.
I guess if you are doing the dry cines rather than contrast cines, eleocrane is totally different, but PA caudal, look left main and those sort of areas. If you're doing a dry acquisition without contrast, you sort of can get away with some of the limitations that you have with contrast.
MS, what is happening? Can you take us to the fluoro, please?
Yeah, that's what we have told them. We are cannulating the right.
Yeah. Okay, so your left man is good. You think you are happy with that?
Yes, I mean, I thought the stent was a bit too much in the aorta. But I guess we cannot stop.
So is there a damping of pressure? Can you show the pressure here?
1 minute. Go on pressure.
I'm on pressure. I'm on pressure.
You're not on pressure.
I'm on pressure.
Just show the screen to
You
them.
pull back the catheter.
Just show the screen to them.
Pull back.
Is there
Pull
a
the
ST elevation?
catheter.
So we were deeply right.
I could see
That's
some
a lot of
ST
damping. The pressure tracing, that was completely in the RCA, very damped.
And there was some ST elevation in the inferior leads when it was engaged.
Huh?
The RC catheter was engaged.
No.
I guess having your wire in the guide might make life easier.
We're not engaged. Where the aorta? We're way high. So we have to keep the wire ready there. Small contrast. Small. Small. Small.
You take this.
MS patient is comfortable, am I right?
Yeah.
Yeah, work wire bhagwan wala. I'll just keep it hidden here. Okay, fine.
Yeah, good idea.
Can you see the wedging?
We can see that it's engaged, deep engaged, but we can't see any pressure.
Show the pressure, please.
Pressures.
अरे तेरा हेमोडायनामिक दिखाना उधर यार. Okay, we are seeing the ST elevation.
Yeah, we are seeing some ST elevation and pressure is absolutely low. I mean, is that the pressure line? The red one?
The red line is the pressure. It is reading 28 and now it is clear.
Okay, so what have you done? You rotated it. Am I right?
No, I pulled it back.
Pull back a little. Okay.
So let me ask Dwayne, who's not a side holds guide fan here.
No.
Dwayne,
No, this was not a side
Yeah.
hose.
This is not
This
side
is the
hose.
picture, little corner.
You know it's damping now, right?
Yeah.
And that's
know.
going to keep happening. Would you use a side hose guide here?
No, I'd pre-dilate.
No, pre-dilate, yes.
Same scoring balloon? Yeah, you can, some concertina
Yeah,
or spasm?
no, it looks like concertina.
Okay.
So.
Is there any angina to? No,
No,
nothing.
No, it is wedged. Huh?
Get some balloon to dilate. Yeah,
It is wedged.
Yeah, it's wedged. You can't see the pressure here.
You can see there on the left lower side.
We can see, but it's become very faint now.
Anyway, right now we are in the aorta.
Correct.
we are got very good pressure.
Okay. All right.
Stent Mango. I get a 4.
Which wire is this?
BMW.
BMT.
Get 424. Yes or no? Yes or no? Okay, inflate.
We have another 15 minutes for you. So I think it will be over by then.
Yeah, yes. This 3.5. 3.515. Oh, stent is ready. 4.3. Okay, inflate.
Do you want a 4 or you want a less?
3.5. 3.524.
25, 24 there. 3.5, 24 stent. 26 असेल 22 का 26 असेल बघ.
Let's take a picture. Yeah. Ready?
Yeah.
Okay. Stent.
Have you used the same scoring balloon here also?
No, we haven't used. You think you want us to use it?
Because it looks like fibromuscular dysplasia, as Zayad Ali said.
Get me that score flex.
You have opened an IVUS. If it's a soft plug, if you use cutting balloon, you just risk no reflow. So I mean, if you open an IVUS, you get your size, you get your vessel composition, everything in one go.
Will you like to do IVUS?
We will, but we are doing a cutting balloon first.
Yeah, okay, that's a good idea.
It's cutting, right? Oh.
Same balloon.
Same score flex.
Okay. But size would be different.
No, this is 3.5. I think the vessel is more than 3.5.
Okay.
$3.5.
20 आणि बोस्टन मध्ये 24 3.5 हा 3 आहे हा 3.5 नाही 3.5 पाहिजेत.
Okay, inflate.
Your guiding is not engaged or it's outside? Outside.
Okay, inflate. Moment you go in, it gets
It gets damped. ST goes up.
Yeah.
Okay.
Yeah.
So this is 3.35 cutting balloon.
Yes. You have 3.528. Hello. Okay.
28 कुठला
One more. 3.528 open.
Okay.
Bring the balloon. Bring the stent rather.
चेक करજો करे रे
No.
Open, sir.
Open.
3.528 को किधर जी पेज होता है तिकडे
on stent.
ST
Get the
elevation,
stent in.
ST
Get the stent in. So we have these typical difficulties of the ostial lesion. Moment the
Yes.
catheter is touching the lesion or the ostium for that matter, the pressure is damping, ST is getting elevated. And at the same time, we are trying to get.
At that time, patient also is getting angina. Am I right?
No angina. Luckily, she's been very cooperative.
Okay.
So Dr. Hermit, it might be a good opportunity to try the bumper wire, but especially it's a relatively simple technique.
Well, I think
More concertina.
maybe we will spend some time together before we start using bumper wire.
But why did you
I
choose
like
a
going a
longer
little more
stent?
LAO, almost as much as you can without getting the arm in the way to see the ostium better.
We have
I see.
LF model.
Maybe not.
MS, why did you take longer stent, 28?
Well, just inflate. Okay. We are good.
Sure.
Yeah. We are going up here.
Okay.
Just go to 8, 6 maybe.
6.
Okay, enough. Save. Okay, inflate.
So Dr. Pinto, you were saying something about angles, is that right?
Yeah, I'd like for the right ostium, I go a little more LAO as close as I can get to lateral without having to put the patient's arms up and waste that time.
Is there any damping now?
No.
No damping now, no?
No. Pressure is very good. Very with contrast.
And now you are engaged also.
Hopefully.
Guiding is engaged into the.
We don't know, but hopefully you are engaged. Yes. Ready? Yeah, we got the ostium correct.
The balloon will retransit the guide catheter.
You think you got the ostium right, correct?
Yeah. So we'll try and get the balloon in and see if we can realign the guide catheter. Okay. Ready?
Yeah, we are correct. It's a correct ostial position.
The distal end is also looking safe.
Yeah.
Okay, I'm pulling out the wire. No, I'm not pulling out the wire. Just another contrast. Go elevocranial.
Is there any plan to do IVAS?
No.
No. Yeah.
Perhaps it looks a little underexpanded in the os. See how it's bigger in the proximal portion?
Yes, you have.
You need to flare up the ostium.
4-0. Go
Correct.
to yes, we are doing that.
Yeah.
Get a 4-4. Another balloon. 4, 4, 5, whatever is available. Oh yeah. Get it quickly.
We still have 10 minutes.
Yeah, but
Yeah, I know. Like to, finish the case and then make your comment.
yeah, I think we had two lesions which were both ostial, and ostial is always a challenging issue. I mean, the guide catheter has to be away. Also, the pressure should not remain quite good.
4 NC.
And going through these two important difficulties, and then we are we are sort of putting in a stent. The left side stent was a little bit too much outside, but the right looks well placed at the ostium.
Wait.
And
Yeah.
we are now doing, we can't find a balloon.
4 NC. 12 आहे कारण हा आपला हे our stent is 28. So
The issue about the ostium is the bed preparation. I think it's generally the ostium behaves more like aorta. That's what we all believe. And that's why something like cutting balloon, high pressure inflations is always a must. On that background, this cutting balloon was quite effective. And on both sides, we seem to have a decent ostial dilatation. Makri, you want to have any comments? Okay, so leave this.
no, I think you have to-
Wolverine is not available in India these days. Am I right?
Yeah, it's not available with us here.
Yeah, even we find it difficult to get it. The company is saying it's in shortage.
Don't hinge it.
Yeah.
Okay, go up. This is 4.5 or 4? 4. Okay, go.
Air bubble ಕಡಿಮೆ ಇದೆಯಾ?
You are outside the ostium, the balloon.
20,
No, balloon is in the stent. So,
20.
yeah, enough.
Now we'll do the stent boost after this.
Yes. Okay.
Get
go
ready
up,
for the stent
Go
boost.
up. Okay, do a stent boost. Come down. Then we do it when it is inflated.
Okay.
Inflate. We can't show it to them, but no. Can we show it to them? Boost.
Boost, stent boost.
Yeah, camera can be,
Camera
focused
can-
on. You have to tell the cameraman to focus on the boost screen.
Up hero. We have to come back little.
Okay, give one more inflation here.
So guide करते free कर दो.
किला है, हाँ.
Okay. बस
ऊपर जाना.
Yeah, that's flared up now. Ostium.
Okay.
Yeah,
Another stent boost.
Another stent boost.
How high did you go?
Off fluoro.
How high did you go?
I'm on 20.
With a 4.5 or 4. 4. The stent is 3.5. So the balloon NC is 4.5.
Stent
And
boost
we have gone to
off fluoro.
22.
Stent boost. Stent boost exposure. Okay.
Different.
वो ऊपर वाला दिखाना. ऊपर वाला दिखाना.
Take one more boost.
Yeah.
So are you able to see the stent boost?
Yeah, we are able to see the balloon and but not stent boost.
No. You're showing
इसके ऊपर
this.
दिखा रहे भैया.
दिखाओ.
Uninflated balloon outside the
ये
guiding.
दिखाओ.
There
Yeah,
we are
because
able to see. Still, the ostium is not completely open, flared up.
Maybe we are in the LEO caudal. That's the reason why we are getting that effect.
Okay. Then which other view? Take LAO caudal is the right view, no, for the ostium of the RCA.
Yeah.
You can try epicaudal.
Okay, give me the epicaudal. Stent boost. Epicaudal.
Do you think we need to go up more
How much did you go?
at the ostium?
Huh?
22.
This is a 3.5 stent and we are using a 4 NC
Correct.
and we went to 22.
So there is a recoil, some recoil sense.
Just show that.
No, it is an face. See, it is an face.
Okay.
Yeah, that's the reason why. See, the orientation of the vessel may be different here.
Yeah, okay.
And that's the
Possible.
reason. So we'll go back to the LAO, plain LAO, possibly.
LAO caudal.
Where it is profiled in lateral.
Slight caudal. Okay,
Yeah,
go down.
balloon
Boost
advance
again. Boost again. नहीं जाना.
Okay, here looks correct.
Yeah,
So it is basically the orientation of the vessel that the ostium.
but still, the ostium still looks not fully flared up.
Good 20, 25.
इधर दिखाओ इसके ऊपर.
Go in the middle, put the balloon in the middle, go in little with the balloon so that balloon is in the middle at the ostium.
I'm going up to 25. Okay, enough.
This is 4 by 12 NC balloon,
Yeah,
and you went up to 25.
25.
Okay.
I think the battery will be the enemy, so we stop here.
So it's difficult to pull out, is it?
No,
No, it has come out.
Ah. Can we see the screen, fluoro? Yeah, looks better. Much better than before.
Yeah.
Can we do one more stent boost and see?
No, I pulled
Now,
out
now the balloon is out.
A balloon is out. Okay. All right. Looks like
Go elevocranial.
एयर क्यों आ रहा है इधर से? एयर क्यों आ रहा है?
Elevocranial. Elevocranial.
No, I'm not ready. I'm not ready.
still engaged. Guiding is still engaged.
Hopefully.
Yeah, no, it's come out a little, but that's good shoot. You can take it so that at
Yeah.
least we, yeah, it looks like it has opened up very well. The ostium of the RCA.
Yes. I think we are quite happy with the
Yeah, we looks like good result both in the left main and the RCA
Yeah.
ostium.
So,
I think it's a
what
great
are,
work.
what are the other ways?
Congratulations from our side.
What are the other ways in which one can do an ostium? I mean, we use the cutting balloon and a high pressure NC balloon. But any other suggestions?
That the bumper wire technique, floating wire technique, and IVAS, all these three techniques have been described for positioning the stent properly in the ostium of the LAD, left main and the RCA. But you used your fluoro judgment, and I think it's perfectly okay. Gave a good result, ultimately and smoothly, uneventful. So I think it's all in all, we should clap for a good case that you have done.
Thank you.
Very nice case and unusual presentation for 46 years old lady.
Yes.
And but unusual, very unusual fibromuscular dysplasia only presenting as a osteal lesion
Only in the coronaries.
Sorry.
Only in the coronaries.
Only in the ostium of
the coronary.
Bilateral.
Yeah.
All right. Thank you indeed for the opportunity.
Thank you.
I
Thank
hope,
you indeed.
You all
And
enjoyed this case.
MS and Makhle, we will like you to join us as a faculty for further. So you have a login detail. So kindly please join in.
Sure.
Sure.
Okay. Thank you.
Thank you.
So now we move further. Is Shripal, can I request you to go ahead with your presentation?
Yeah, I know, absolutely. No, again, thanks for having me on, and those were
Of course, and we
interesting.
are very grateful for you to spare your time on a working day. All of you, I mean, entire faculty, I'm very grateful to.
Yeah, those were interesting cases. I mean, tough cases with osteal involvement.
Correct.
Let me start my presentation. So I hope you can see my slides. I'm going to go on a slideshow.
Yeah, we can see your slide, and we can see you also, and we can hear you.
Okay, fantastic.
Okay,
so I'm going to discuss about left main bifurcation PCI. I mean, not the ones that we just saw, not an osteal left main, but left main bifurcation PCI. What is the evidence-based approach when you're trying to choose between a provisional approach versus a two-stent technique approach? And I want to start with this historical perspective. There is this notion, and it may or may not be true even now, but the historical notion is if you do a two-stent technique, I mean, this is data from a long-term follow-up of the Nordic and the BBC1 trial. These were trials looking at provisional versus a two-stent approach for bifurcation, not necessarily left main, but bifurcation lesions. And what was shown in these trials, even at 5-year follow-up, is two-stent technique at higher risk of stent failure, higher risk of adverse events, and including here, as you can see, 5-year increased risk of all-cause mortality. So I want to start with this historical perspective. I mean, this is what we were taught, and and I think this is what people still believe in, and this is why provisional technique has been floated as the way to go. But the key thing to recognize from many of these trials, or for example, this Nordic and BBC1, the stent used in Nordic was a Cypher stent and BBC1 was a Taxa stent. So it's a first generation regulating stents. And we know even though these stents are great at preventing restenosis, they're not as good as what we have currently. And the risk of stent failures were higher with the first generation stents. The second point I want to make is the two-stent technique used in all of these older trials. Many a times we tend to lump all of these older trials together and kind of come to a conclusion about whether we should do provisional versus two-stent. But the two-stent technique used in this, for example, these two trials were Culat, the traditional or the classic crush, and the D-stent technique. So some other point to recognize. So in terms of the stents, we have made significant progress in DS technologies. That Taxus and Cypher used in Nordic and BBC1 were 132, 140 micron strut thickness. So we've come a long way, much progress. Stents have become thinner, and now we have ultra thin stents. It's not just that the stents have become thinner. What we have also shown, and it's been shown in a number of randomized trials, is there have been significant progress in improving outcomes that we all care about. For example, this is data from a meta-analysis of 250,000 patient years of follow-up from randomized trials, and we see there is significant progress made in reducing restenosis with the current generation drug-eluting stents when you compare it to the previous generation stents which were used in the Nordic and BBC1. Not only have we reduced restenosis, we have also made a significant impact in reducing myocardial infarction with the newer current generation drug-coated stents. And we have also made a significant impact in reducing stent thrombosis. We have cut down the stent thrombosis by 2/3 compared to older generation stents. And finally, if you look at the reduction in mortality, of course, if you have like so many patients years of follow-up, you can see some small signal towards a reduction in mortality. So this is key to recognize because the whole older provisional two-stent techniques were with the older generation stents. The question is, does it apply to what we do in current day practice? Not only as the stents changed, there has been significant progress in two-stent techniques also. And this is a review article we published recently in Neurointervention, just focusing on crush technique. In 2003, there was the classic crush. Then we went to the step crush technique, then the original DK crush. Then we had a contemporary classic crush, mini crush, DK crush, nano crush, and now the DK nano crush. I mean, I can tell you that DK nano crush is my default two-stent strategy for the last 4 or 5 years. And of course, 4 or 5 years ago, I was doing the modified version of the DK crush. I used to call it the Bangalore modification. And of course, more recently, it was named the DK nano crush technique. So not all crush techniques are the same. So you see that there have been progress in even two-stent techniques. And the other point I want to emphasize is not all two-stent techniques are created equal in terms of outcomes. I mean, now we have head-to-head randomized trials. So this is the DK Crush 3 trial, comparing DK Crush technique versus Culat technique. This is in patients with left main bifurcation lesions. So just over 400 patients who had true left main bifurcation lesions. So it's either 011 or 111 lesion. These patients are randomized to DK Crush or Culat technique. And in this trial, a DK crush was led to decreased TLR-free survival and also a decrease in the risk of TVR. And interestingly, this is the 3-year follow-up of the DK Crush 3 trial. Again, you see continued superiority of DK Crush technique, reduction in 3-year overall MACE, reduction in myocardial infarction by more than 50%, significant reduction in TLR, TVR, reduction in stent thrombosis. So it's interesting to note that the Coulthard technique, stent thrombosis rate of 3.9%, DK Crush of 0.5%. So what I want to use these slides is to show that not all two-stent techniques are the same, not all bifurcation trials are the same. So I think we really need to apply what we do today and use evidence to support or refute what we do today. So this is network meta-analysis. I mean, again, not really restricted to left main disease, looking at provisional versus various two-stent techniques. And in this meta-analysis of 21 trials, 5,700 patients, you can see here anything to the right favors provisional, anything to the left favors a two-stent approach. And you can see other than DK crush, all other two-stent techniques did not provide superiority to provisional. So in other words, no difference between provisional and other two-stent techniques except for DK crush. And DK crush was associated with significant reduction at 71%, 61% reduction in MACE when compared to provisional technique. So that would be the first take home, that not all two-stent techniques are the same, and even the outcome, there may be differences within different two-stent techniques. So now let's focus on left main bifurcation. So we're not talking about ostial left main or midshaft left main. We're talking about true left main bifurcation. So you either have ostial LAD, ostial circ 011 Medina classification, or true involvement of all three parts of the bifurcation. So distal left main, ostial LAD, ostial circ. So what is the evidence for a routine two-stent approach? And this basically stems from the DK Crush 5 trial. So this is 480 patients, true left distal bifurcation lesion, patients randomized to DK crush versus provisional stenting. And the primary endpoint was at 12 months. And you can see there was a significant 54% reduction in target vessel failure with the DK crush compared to provisional stent technique. So interestingly, this is one of the first few trials where putting in two stents using a DK crush approach was superior to just a provisional approach. And this target vessel failure was driven in target vessel MI and also target lesion revascularization. What is also more interesting, significant reduction in definitive probable stent thrombosis with DK crush when compared to provisional approach. It's also important from this trial to note that if you opt for a provisional stenting approach, as was done in one arm of this DK Crush 5 trial, there was 1% acute occlusion after main branch stenting. So if you're stenting across the main branch, there is a 1% chance that you may have an acute occlusion of your side branch. So you should be ready to bail out. And in this trial, the crossover to a two-stent approach was in nearly half the patient, 48% of them, and mainly with the T-stenting or TAP stenting. And there has been a longer-term follow-up of the DK crush. This is 3-year follow-up, and you see continued separation of curves. This is for target lesion failure. And we see, even though the biggest separation is within the first 12 months, you see continued divergence of curves. So continued benefit of a DK crush compared to provisional stenting, reduction in target vessel MI, target lesion revascularization. And here you can see the increment year to year in target lesion failure reduction with a DK crush when compared to a provisional stent approach. So that is one trial. We can't hang our hats on just one trial, and sometimes it could be play of chance. And of course, with just like at any experiments, the more you do repeat those experiments and show consistency of results, more we can trust those data. Do we have any other trial to support a two-stent approach? I mean, we have the definition 2 trial. 660 patients, not really all left main. And this was complex bifurcation lesion. Interesting to note that 1 in 4 patients had left main disease. So it does apply in the sense that there was 28% patients who had left main disease, randomized to 2 stent versus provisional approach. And important to note that the lesion length in the side branch, which we'll come to at a later point, was around 20 millimeters. So this is pretty, it's not a very short side branch lesion, but greater than 10 millimeters. In this, the average was around 20 millimeters. And if you had the 2 stent approach, the 2 stent technique was mainly DK crush in around 78% of patients. If it was provisional, 22% of them converted to a 2 stent approach, and the 2 stent technique used mainly was TAP. And of course, there was a high use of final kissing balloon inflation in both them, and a high use of POT after kissing balloon technique. And in this trial, again, you see that 2 stent approach was associated with a significant reduction in target lesion revascularization, target vessel MI, and target vessel failure. So findings very similar to what we saw with the DK Crush 5 in this group of patients with complex bifurcation lesion. So at least we have 2 trials which seem to support a 2 stent technique in patients with complex bifurcation lesions. So what is the, so now we have another school of thought where people favor a provisional approach. And so this is driven by the EBC main trial, which was recently published. EBC main is a randomized trial of 467 patients, again with true distal left main bifurcation regions. Patients were randomized to a provisional approach or a systematic 2 stent approach. And I must say, the EBC group is very good with this provisional approach. I mean, it's not just a provisional approach, it's called a layered step-by-step provisional approach. And I think, that's been my go-to provisional approach if I were to follow a provisional strategy. In this, if you were to be randomized to a provisional approach, the POT was mandated, KISS was mandated. In the systematic 2 stent approach, the operator could choose which 2 stent technique to follow. And high pressure osteal bifurcation dilatation was mandated, and kissing balloon inflation with or without final POT was mandated. And interestingly, so I think this is something that we should discuss slightly more in detail. If you look at the systematic 2 stent approach, which was used in EBC main, it was, to me at least, it was disappointing to see that only 5% of the patients had a DK crush technique. So this was mainly a trial which looked at culotte or T or TAP technique. And compared that with a provisional technique where 22% of the patients had 2 stents, and the 2 stent was mainly using culotte or T or TAP technique here. And of course, rest of the procedure was done, high rates of kissing balloon inflation on POT use. And if you look at the primary endpoint, was death MI TLR. In contrast to DK Crush 5, there is no significant difference. If anything, numerically more events with the systematic 2 stent approach when compared to provisional approach. And if you look at all endpoints, including TLR, again, numerically more TLR with 2 stents when compared to single stent technique, provisional approach. So why is there a difference? I think it's important to highlight this, because this will be fodder for good debate. But what do we do with these 2 trials, which seems to come to opposite conclusions? So these are some slides from Davide Capodanno. I like the animations that he does. EBC main and DK Crush, both were similar size trials, multi-center randomized. The key difference to me is the side vessel length lesion. So in DK Crush, it was 16 millimeters. In EBC main, it's 10 millimeters. We'll come back to, 7 millimeters. We'll come back to this. And I think this is very critically important as we choose our bifurcation strategy. In the provisional arm, 22% in EBC main, but 45% in DK Crush got 2 stents. And I think the plan to stent strategy is where there is a major difference. In DK Crush 5, it was DK Crush. In EBC main, very low use of DK Crush technique. So people like me would make an argument that in DK Crush 3, Culotte was found to be inferior to DK Crush. So why would you design a trial where the majority of patients got Culotte? And the IVUS use, I must say, is disappointingly low in both of these trials, even though it's a left main with only 40% IVUS use. And you can see the primary endpoint, significant reduction in primary endpoint with DK Crush, but no difference in ABC main. Again, you see the vessel prep and part use and side vessel stent, and we talked about the side vessel lesion length, and you can see, I mean, there is fair comparability in what was done kissing balloon inflation and part with this, and you can see the outcome comparison with if you look at death, no significant difference in either of the two trials. The difference is TLR, no difference between two stents and provisional in EBC main. The two stents is in this light purple, whereas in DK Crush, significant lower risk of TLR and also stent thrombosis with a two stent technique when compared to single provisional technique. And in DK Crush, they looked at whether the left main bifurcation was complex versus simple. And the definition of simple was if the side branch lesion length was less than 10 millimeters, and if the diameter stenosis was between 50 and 70. And interestingly, the absolute reduction, absolute benefit of a two-stent approach seems to be more in complex lesion when compared to a simple lesion. But of course, the test for interaction was not significant, suggesting that the result applied to both simple and complex lesions. So what do I take from all of this? So I think it's critically important to characterize your left main bifurcation. I mean, to plan out your stenting strategy. And I tend to do this even if I don't see much angiographic disease in the circumflex. I'm sure Dwayne Pinto will go over in more detail, and you'll hear from Ziad. So even if there is not much disease, I tend to do IVUS both limbs, or any OCT or IVUS in both limbs. And the things we are looking for is side branch characteristics. What is the size? What is the diameter? What is the severity of stenosis? Not just angiographic, but also plaque characteristics. What is the length of the side branch lesion and other characteristics? And also looking for bifurcation angle. And to kind of summarize my general philosophy for this is, if the side branch, for example, if the ostial circ is normal, and when I say normal, it's angiographic normal, but also make sure that on IVUS imaging, you're not seeing a huge plaque burden. I tend to go with the provisional approach. If the circ, of course, is diminutive, it's less than 2.5, supplying a very small territory, non-dominant circ, of course, it's a no-brainer. You do a provisional approach. For two-stent technique, if it is a diseased circ, if it's a true 111, 101, if it is a large circ, 2.5 millimeters or greater, and or the lesion length is 10 millimeters or greater, I tend to use an upfront two-stent strategy, and my preferred two-stent strategy is a DK Crush. And I think this is critically important. If you anticipate you're going to have difficulty accessing the side branch after main branch stenting, you'd rather do an upfront two-stent strategy. And also if there is a high risk of vessel closure. But I must say that, I'm very comfortable with the DK nano crush technique. So if a patient is crashing, I have a cardiogenic shock, the patient is like acutely decompensating in front of me. I actually do a DK Crush, because for me, DK Crush takes like a minute and a half, then to stent across provisional and wonder what happened to your side branch, crossing, recrossing, etc. The same applies. Ziad and I do a lot of zero contrast PCI. So if I have a patient with advanced CKD and there is a true bifurcation lesion, I tend to use DK Crush. Again, because if I do a DK Crush, the amount of contrast I use to figure out whether my side branch is compromised is significantly minimized. And in many cases, you can do zero contrast, complete zero contrast. And in those cases, I tend to use two-stent upfront DK crush technique. Let me end by just showing one of the cases here. So this is a 61-year-old guy, hypertension, hyperlipidemia, family history of premature CAD, came in chest pain and troponin elevation. And when we did an angiogram, you can see this heavily calcified critical left main disease extending to both branches. So there is, it's a true 111, and it's, you can see it's very hazy, suggesting that this is a very very critically stenosed lesion. I'm trying to see if I can move this panel somewhere. All right, so let's see, let's leave it there. Okay. And another view of this, again, you see that critically stenosed the left main 90% extending to ostial LAD. There is some mid LAD lesion there. One more view in the caudal view, looking at the bifurcation here, again, you see at least a 90% heavily calcified circumflex stenosis. The right coronary artery did not have any significant stenosis, but what is interesting to note is you can start seeing collaterals going into the LAD, which is always a bad sign when your LAD is not occluded, but you start seeing collaterals to it. So to summarize this particular patient, he has left main bifurcation, heavily calcified in both limbs, severe mid LAD. Syntax score is 14. You'd normally have, I mean, if we took him off the table, we wanted to make sure like he understands his options. And after much discussion with the heart team, he opted for PCI. So this is what we did in his case. So this is a true bifurcation lesion, heavily calcified. So we did not want to lose the circumflex. So we did a dual guide approach. So we had a 7 French EBU 375 from the right radial and a 6 French EBU 375 from the left radial artery. And I'll tell you in a second why we choose to do a dual guide. And the reason for this was we wanted to rota both limbs. And at the same time, given that these were hanging by a thread, we wanted to protect each of the limbs. So the LAD as a rota floppy, circumflex as a run through with the turnpike LP microcatheter covering it. This is important so that you don't shear your wires. And now we are doing a rota into the left main here using a 1.5 burr. So then we switch this around. Since we have two guides, it makes it easier. So there is less interaction of the rota if you use these two guides. So here you can see there is a circumflex guide, there is a LAD guide, and then we flipped it around. Now we have a microcatheter covering the rota floppy wire. We used a second rota wire for the circumflex, and we burred into the circumflex. So here you can see we're burring into the ostium of the circumflex. And of course, then we followed the usual DK crush strategy. Here, first, we are dilating the mid LAD with a 1:1 sized NC balloon to make sure that since we had only used a 1.5 burr, wanted to make sure it fully expands. The same 3.015 NC left main into the LAD. Now we are taking a 3.015. I mean, since we have two guides, it actually makes the workflow very fast. You can just withdraw one of the balloons. You have the other balloons up and over, ready to go. 3.015 NC left main circ. We are implanting a 3.523 Zions in the mid LAD. This is 4.023 Zions in the circ. This is the blocking balloon for your DK crush technique. And we're pulling the stent balloon back. We are kissing with the balloon in the left main LAD. This is the part of the nano crush. And of course, since we have two guides, it looks atypical than what you're generally used to with a DK nano crush, with a kissing balloon. And here we are removing the wire from the circumflex and then crushing that with the 3.523. Now putting in a left main LAD 4x23 Zion stent. We are following that with the pot with the 508 NC balloon. and we are doing a kissing balloon inflation. Now we have two 4-5 by 12 NC balloons. And this is very important. I mean, the main reason I use 7 French in left main is because of the size limitation of your kissing balloon. So if you're using anything closer to 4.0 NC balloons, if you're using 2 of those, you need at least a 7 French system. So I think that's important to recognize. Here we used 2 4-5 balloons. And then we did some imaging and we saw that the lady needed some more post dilatation. Now we have a 5.0 and a 4.5 kissing balloon. So you can imagine these are big arteries, and we are kissing with a 5.0 and a 4.5. And we did a repart technique with a 6.0 balloon. And of course, finally, these are some of the final results. We did IVUS both limbs. Everything was well opposed. The MLA in the left main was over 10, and you'll hear more from Ziad about it. Another final view of this technique. So you did pretty well. I know in the interest of time, I also have to run. I mean, they're texting me about my patients on the table now. So we published this in JACC Intervention. This is a protected rotational atherectomy with DK nanocrush repart technique using a dual guide approach. Let me stop there. I'll take any questions.
Yeah. Thank you very much. Just a question. You say that your default technique for all angle is nano decay crush. Correct?
Yeah, that's correct. So I tend to use it for most of the cases. That's correct.
Yeah. So any angle.
Most of the angles. I mean, the only exceptions would be if the angle is extreme, for example, more than 90 degrees, right?
Yeah, okay. And what do you mean by nano means number of struts overlapping less?
Yeah, so the nano
Crushing is less. Crushing is less number of struts.
So the nano it's a 1 to 2 millimeter protrusion into the main vessel, whereas the traditional the DK crush is 3 to 4 millimeters. So you're protruding only by 1 to 2 millimeter, but also you're doing a kissing balloon inflation with the stent balloon. That kind of helps you with the recrossing much easier, and it saves you a step.
Your both vessels were of equal size. The case that you showed.
Yeah.
But you didn't consider the DK culotte. This is DK culotte is another thing which has come up.
Yeah, so that's more of a newer adaptation. But what I see is there are some subtle variations in many of the things. I tend to like less metal in my main branch, and so I tend to stay away from culotte if possible, because I don't like the concept of having 2 layers of metal in a main vessel.
Same here. I prefer mini crush or decay crush to culotte, but nano is still not in our practice. So we have this new thing that you said nano for all practically even up to 90-degree angle. So that's great. I think it accommodates most of the range of the angles as far as the angle is concerned. Now coming back to the...
I have a minor comment.
Yes.
In that very much in the United States, Sripal, you can comment on whether this is something you've heard, is that, only Xiaoliang in First Nanjing Hospital can really get the results of DK crush, and that it's very technically demanding, and a number of excuses, I think. And it's a Western-centric way of thinking, because if this trial had been conducted in the West, it'd be the definitive trial. But because it really doesn't make any sense to me, and if you're really saying that DK crush is so demanding and so difficult to do, then you must mean that they're really good at DK crush, but must not be good at culotte, because it's a randomized trial. So that makes no sense to me either. And I find actually in my practice that culotte is more difficult to do than DK crush. So I actually reject this criticism that only the Asian operators can achieve these results as we're seeing in the DK crush studies. But I hate to be contentious, but that's my belief. I'm sorry. And the other is the sleeve technique that Sripal showed. You can accomplish this with an 8 French catheter, a single catheter, using a fine cross, which is the smallest profile microcatheter, and orbital atherectomy if you have it available. And so we've done that for some left main lesion.
Yeah, no, absolutely. I think, that there are so many excuses, and the excuses seems to far outweigh what the robust data from randomized trials. So I think, it's time people get the training right. And I think we on the panel, we do so many DK crushes, DK nano crushes, and you have a patient in cardiogenic shock crashing in front of you. I mean, it's the 2 stents are in within 2 minutes. I mean, minute and a half. I mean, it's that quickly, as long as you know what you're doing. And I think that's the critically important part of it.
So I think we had a great discussion. We always say that do what you are comfortable with. So that ultimately is the right approach, I believe, because one side we see Joanne wants to do Tulot and you want to do nano DK crush. So that's okay, I think, as long as the results are acute and
you know what? I'm totally with you, Dr. Bang. But yes. When you're not comfortable doing DK crush, say, I'm not comfortable doing DK crush.
Absolutely.
Don't say, you know what, I don't believe the data because it's only this operator.
No.
And that
data is there, but I believe in that data.
Yeah, if you're honest about your limitations, you can learn. If you use excuses, they're only excuses.
Correct. Absolutely. I have one more question, Dr. Sripal, that how often in DK nano DK crush, how often the ostium of the circ come back with the ISR?
So that's a great question. I mean, there isn't a randomized trial which has used DK nano crush. I mean, we know from DK crush 5 that the ostium of the circ, I mean, I'm sure Dwayne is going to address this later.
Yes.
I mean, in that trial, at least it was 5%.
5% and 12% with the mini crush.
12% with mini crush. So, I mean, it's still low, but most of the restenosis tend to happen in that ostial circ.
Okay, that's great discussion.
We're talking about the difference between thick strut and thin strut, and there are strong beliefs about that, but yet we kind of suspend reality when we say, let's put a whole bunch of metal crinkled up in one corner of the artery, and that, may be better or worse. We don't really know, but I think if you really believe a lot of metal crinkled up against an artery is bad, then anything that leaves a lot of metal crinkled up against an artery is bad. So we can't both say that thin strut is better, but I like to leave a lot of mangled metal.
Any panelist has any other comment? No, so I think we let Dr. Sripal say thank you very much and let him go so that he can go, because it's a working day, so he would like to go early. And, if you can come back, I would love to have you back. And the next talk is Dr. Jihad Ali. Is he there? No.
Hi, I'm here.
Yeah, okay. So I think...
So I also have a patient on the table, so I'm going to sort of get started and then move through this fairly quickly.
Okay.
Because we have a MitraClip on the table.
Okay, fine. Absolutely.
All right.
Fine.
So my task for today is to talk to you a little bit about intravascular imaging and CTO. And so really what I'm going to do is focus on the case presentations to show you how we use this in real practice. So here's the first case. This is a live case at TCT that we did, a 70-year-old male with a history of COPD, hypertension, hyperlipidemia, smoker who had under-controlled angina. And the patient had severe COPD, and the thought was that the risk for CABG was greater than PCI if the PCI approach was available. So what you can see is the right coronary artery is normal right away. You can see there's a very dominant septal. This is actually one of my favorite views, which is the REO, slightly REO and heavy cranial to look at collaterals. My second favorite view is REO 30 or either cranial 10 or caudal 10 to identify the septals. And what you'll see, of course, is that there is no LAD. So this is often the case when you get a flush occlusion. Believe it or not, flush occlusions happen more when you have a ramus than if you do not have a ramus. And the reason for that is there's a easy path for the blood to go down once there's an occlusion of the LAD. So you can see that there should be a vessel in the middle. You can't see anything. You can actually see it retrograde filling from a diagonal branch. So we know that there's a severe stenosis or a CTO. The patient has an anterior wall motion abnormality, and because of the indications of ongoing angina, we decided to take an approach of an imaging-guided CTO PCI of the flush occluded LAD. And the question is, do you take a primary antegrade or a retrograde approach? For those of you who are interested, you can actually watch Dimitri and I do this live. So this is a dual access case. Obviously, to try to take a poke at this would be a big mistake. And so when we're going to try to attempt these things, our typical approach is to go with the big guns. So we'll use an 8 French guide to the left side, and on the right side, we typically use an AL with a guide extender. Here's our duals. And so the duals speak for themselves. You can see that there's a very dominant septal, and for the most part, this is a favorable anatomy. Now, one of the complications of this or complexities is when you get retrograde, if you don't have enough running room to get into the distal cap, that can make things difficult. But actually, you can see that there's probably about 10 millimeters, maybe even 15, up to the distal cap if we go retrograde. So that actually makes the retrograde option very favorable. And so now the next question is, if you go retrograde, that's not enough. You actually have to make some progress antegrade in order to make the connection. The reason you have to do that is if you go retrograde, the wire, especially if it's a hydrophilic wire, is most likely to go subintimal in the left main. If the wire exits the left main and you stent it, you will close the circumflex. I hope that makes sense. So if you go retrograde and use a hydrophilic wire and it tracks subintimally over the left main and you finally exit either in the aorta or in the left main, when you stent it, there will be a flap between the circumflex and the LAD. And so here is what it looks like. This is dual imaging. So I want to focus on a couple of things here. So you see the OCT has a very high resolution, but it's very difficult to interpret. So actually this is the cap. So you can see that the cap is heavily remodeled. You can see the calcium on both arteries, which is here and here. And this is what the cap looks like on the IVUS. Now, the reason this is so important is because now we've confirmed where we need to go antegrade to make a little bit of progress. So this is us going retrograde. You can see that it was actually a pretty straightforward retrograde wiring. This is just a regular Xi'an wire, and you can see we're already up at the distal cap. Okay, so then we like to confirm this with a little injection, make sure we think we know where we are. And you can see this is a turnpike LP. And that we're slowly taking up the retrograde channel. And now we swap here to a Gaia second. Now the reason to use a Gaia second is you really want to make a little progress intraplaque. You need something sharp. And the hydrophilic wire is more likely to be uncontrolled and end up subintimal. And so what you'll see here is now we're in the position to IVUS again. We have a wire in the ramus. We have our retrograde turnpike and the Gaia second near the cap. Now the question is, and this is critically important, is you need to puncture in the LAD into the left main, not the left main into the left main. And this is how you know that you're doing that. I want you to focus here. The wire is in the ramus. So this wire right here is in the subintimal space, okay? But what that's telling you is the wire is actually in the left main. The image on the right side is our original image where you can see the plaque, okay? This is the original plaque here. And when you do these side by side, you can see there are retrograde wires actually in the LAD ready to pop through. This is a really important image because, as I said, if the wire tracks proximally, you can close the vessel. So here you can see that because it's such a short cap, this is the Gaia, we actually pop right through. You can see we enter the aorta. And then we typically actually spin the microcatheter through and make so that we've actually created a small channel, and then either externalize by using a snare or externalize by pulling the microcatheter back slowly. And this is the removal of the turnpike. You'll notice that what we're doing is pulling the left guide completely back. Otherwise, it's going to get sucked in and you can damage the left main. So this is the protection of the septal. We'll typically leave the microcatheter in the septal to protect it. And then we'll put a circumflex wire in, and that circumflex wire is now going to be our protection against the possibility of a flap. And then this just becomes a relatively straightforward IVUS-guided PCI. So we mark the distal reference, take a dual to make sure we are where we think we are, and then IVUS the RCA to make sure that there's no problems. That's a typical plan for us, is to use the IVUS and the RCA. And then we start deploying our stents. And this is our left main stent. We perform a pot, and this is our final angiogram. So you can see how critical the intravascular imaging was in this case for three things. Number one, it allowed us to identify the proximal cap before we started. Number two, when our wire was retrograde, we could actually confirm that we were where we thought we were. And finally, it also allowed us to IVUS the proximal RCA to make sure that we hadn't caused any damage by the deep guide. This is our final repot. We check our distal vessel to make sure there's no perforations. And then we do our distal optimization, proximal optimization, and then a final IVUS. So you can see here how well our circumflex is protected, because we were very careful about where our wire came out. And that's the final angiogram. Here's a second case, very similar, patient with a little bit of renal disease, EF is 25%. And so here's the diagnostic cath. Okay, so again, you'll see that there's a missing LAD. And here's our retrogrades here. You can see that there's a retrograde of a bunch of different retrograde septals. Again, you'll remember you want to go for the septal that gives you the most running room. And so these are our three views to help us decide which retrograde axis we want to get. And you can see that there are a number of septals. Now, I think this one is probably going to be the most dominant. And so that's my plan, to use that. If I end up going with the wire and the wire ends up in a septal, I will actually try to take it. So here's our dual injections. Patient has an EF of less than 25% with no bailout, so there's an impella. And so you'll notice that the first wire actually goes up somewhere, but I don't know where it goes. So the Xi'an is into a septal without a connection. Now, that's not unusual for me to just take the Xi'an wire and take it up a septal and see where it goes. If it goes, I'll take it. If it doesn't, I'll leave it. You'll notice I also left that wire in the septal as a marker wire, and this is a SUA wire going in the LAD via the septal, and you can see that I'm actually into the diagonal here. So this is to make progress retrograde. This is a Miracle 6 to penetrate the distal cap, and then a Gladius Mongo to get me close to the cap, and then I stop. And this is the key here again. The IVUS is going to confirm that the retrograde wire is in the LAD. I'll just let you know when I see it. You can see that the wire is right here. So this is when you're imaging from the ramus on the ramus wire, you'll see this is the LAD up here, and this is the wire in the middle of the LAD. That's what really allows you to safely push the wire. So finally, this is a good place because the wire is so close to the main vessel that you can use a penetrative wire. So this is a CP12 to the proximal cap. And then we used an antegrade field direct CT. We typically do this to make sure that we have no cap ambiguity. And then we use the CP12 to make the connection. And then from here, we actually switch to an antegrade case. This is a dual lumen microcatheter. And then this is our post-pull by HD IVUS. So what you're going to see is here, as you come along here, is you're going to see the sections that were true lumen, because you can see all three layers of the artery. You can see an intramural hematoma from where my retrograde wire was. And then right after the branch, which is also typical, we end up being true lumen again with intramural hematoma outside. So this dark space is the hematoma that I've created from the retrograde wire. Now, what this tells you is a couple of things. It tells you how big the artery actually is. And here's the true lumen of the CTO, I should say. So this was the CTO segment. You can see we're in the false lumen here. This is the connection area just up to the LAD. There's the true lumen up here. And then you see the wire pop back into the true lumen of the left main. Right there. So what do we do now? We measure the distal reference. You can see it's 2.73 by 2.48. The proximal reference is 3.87 by 3.7. So we can choose our equipment. So this is just stenting based on the IVUS, 2.5 by 23, and then a series of stents. And this is our final angiogram after IVUS optimization. So again, you've seen in 2 cases where the IVUS was absolutely critical for us to know where we thought we were and how to do a proximal cap puncture using live IVUS. This is my last case. Again, I'll make this quick. This is a patient who had a STEMI, actually, complete occlusion. And you'll see that the operator, quite rightly, to meet door to balloon time, balloons, and then there's a large clot burden, they aspirate, and then they place a stent. So the patient goes home. This is the final IVUS. Okay, so the final IVUS actually looks good except for some proximal malapposition. The operator decided to leave that given it was a STEMI. But the patient comes back a year later with ongoing and unremitting chest pain. So he's gone to the hospital about 12 times complaining of chest pain, and every time the doctor says, oh, this happens after you have a big heart attack. So what do we find? When we do a review of the angiogram after a STEMI, you'll notice that he's actually missing a very, very large diagonal branch. And so he's been having chronic stable angina as a result of this ever since. Now here's the problem. Even on the angiographic review, the diagonal is missing, but it's very, very hard to visualize by angiography. So if you look on the baseline, you really can't easily see the side branch. You have malapposition, but if you look on the relook, again, you don't really easily see a hint of the IVUS. And this is when the difference between a 40 megahertz IVUS and a 60 megahertz IVUS. So I tried here to do a blind stick, but the blind stick doesn't get me anywhere. I don't have enough support. And so what I did here is use a high definition IVUS. And this is actually really important because the high definition IVUS is going to show you something that you could not see with the 40 megahertz IVUS. And it's right there. Do you see that? You cannot see this at all by the conventional IVUS. But on high definition IVUS, you very clearly see where the CTO diagonal branch is. And so if you do a review of all 3, you again notice that using the original 40 megahertz IVUS, only 60 megahertz IVUS was able to show the occlusion. So now that we've marked this, we did a pot, and then we do a live IVUS puncture. So to do a live IVUS puncture, what you do is you put the IVUS catheter immediately adjacent to the occlusion, and you use an uncovered stiff wire like a miracle to push the wire in. And this is that happening right there. You can see the IVUS catheter is right next to it. I pull the IVUS back when it's next to the lens, and it will penetrate the cap. There you go. You see how we're starting to make penetration? That's how you do that, because you can literally see the IVUS working right next to you. And so if I play this, hopefully it'll play, you can see that actually the wire
is there in the middle.
Is in the middle of, it's right here. Okay, so now once we're in here, again, you can see there's such poor collateralization, except for this very, very faint diagonal. We can advance this to make sure that we're in. Now we wire it under IVUS guidance, and you're going to see how big of a burden of disease there really is. Okay, so we exchange the CP for a turnpike, advance it, do some pre-dilation, and this is the IVUS after the crossing. So watch this, look at this, where the true lumen is. True lumen is crushed all on the side. There's a huge burden of plaque. And then this is as simple as doing a reverse crush. So this is simply stenting, pot with a 5.0 balloon. This is the final IVUS from the side branch. You can see we've crushed all the old true lumen out of the way. And this is our final shot. So you can see what a large diagonal branch was and why this patient was having so much difficulty in symptoms as a result. So just 3 quick cases to show you the example of how you can use IVUS to identify and puncture the cap in real time. And I hope that was useful. Thanks
absolutely, absolutely brilliant cases, no doubt about that. And first time I'm able to see this live cap puncture under the IVUS guidance. So great cases. And the long-term results, any idea about these patients had good long-term results? Did you get to do angio for them?
Well, we follow most of them clinically. But you know, as you know from the decision CTO data as well as the progress CTO data, these are very robust results. So remember, these are all imaging guided PCI, so they tend to do very well.
Very good. Excellent talk. And your case is on the table, so I can't hold you more. And thank you very much for your kind deliberations. Thank you very much. So let's go for the next talk. Next talk is Dr. Anirban Chowdhury. He'll enlighten us on complex LMCA PCI case-based learning. He's from UK and he's known for his work in complex cases. Most of all his cases that he does is very complex cases.
Can you see my screen?
Yeah, I can see your screen. I can see you, and I can hear you also.
Great. So good morning or good afternoon, depending upon which part of the world you're in. Thank you for Dr. Bang to invite me again to be part of this CME day. So yes, you have asked me to speak on essentially case-based learning. So what I've tried to do is concentrate on case examples rather than any theory which has been covered to a certain extent by the previous speakers. So this is covered by.
Can I make a brief comment? You can take longer because the Ziad finished it a little longer.
So Shripal has covered this to a certain extent. So this is how we approach a bifurcation PCI, for which obviously left main PCI is the most important of the lot. And a lot of the approach to bifurcation PCI is essentially dictated by your side branch. So we first look into whether it's a true bifurcation or it's a non-true bifurcation. By non-true, it means it does not involve the side branch. And if it doesn't involve the side branch, it is a provisional strategy unless something goes wrong during the PCI. And if it's true bifurcation, then you try to decide whether provisional is adequate or you require some upfront two-strand strategies. Look at the size of the side branch, which for a left main is often the circumflex, and which is usually a significant side branch. So you have to look after the side branch. Again, look into the extent of the disease in the side branch, because if you have only osteal disease, even if it's true bifurcation, most of the time you have excellent results with provisional. But however, if the atheroma progresses and extends beyond 10 millimeters, at times you have to consider a two-strand strategy. And this was slightly covered in the differences of the EBC study as well as the DK Crash 5 study, the difference between the two studies with the extent of disease in the two side branches, which might have made a difference to how the outcomes between provisional and two-strand might turn out to be, depending upon the disease in the side branch. Specific anatomy is obviously left main is the most important anatomy in majority of people. And finally, the angle of the side branch. At times you might find that it is not a true bifurcation or the disease in the side branch is not significant, i.e. less than 50%, but the angle is so shallow that you could have a carina shift, which can cause compromise of the side branch. And you have to take that into account. Now that really is the factor in the left main unless it's a trifurcation. And taking all these factors into account, we try to devise a strategy from the outset if it allows us that time, depending upon the presentation of the patient. And we go forward with a particular strategy. And if it goes wrong, we have to be prepared for a plan B. So that's how we typically would plan a bifurcation if we have the time to plan for it appropriately. And essentially, in summary, it is dictated by anatomy. So you look into the anatomy, you carry on with the procedure, looking into the vessel diameters, the plaque distribution, the length of disease in the individual daughter vessel and the parent vessel, the bifurcation angle, etc., etc. And we start a procedure and we reassess and assess during the procedure. And at times we have to adopt and adapt a different plan if required. So I'll now move on to cases. And the aim here is to show you different type of cases, touching on the topics of when to do left main PCI, when not to do left main PCI, and if we are doing it, how we can tailor the appropriate strategy for an individual patient. So this is patient one. So this is a 65-year-old lady who had a few admissions with atypical chest pain, finally had an angiogram and went for a bypass surgery in view of ostial left main stenosis. The patient then represented back about 5 months afterwards bypass, and then again 9 months after a bypass operation. And in the second admission, she was thereafter reviewed by cardiology in view of her second presentation. A repeat angiogram was done, which essentially showed that the bypass grafts were blocked. And then when you look into this, into details and image the vessel, you find angiographically, it looks there is an ostial left main, but when you image it, there isn't really any noticeable disease in the ostium of the left main. And this is because of the origin and the course of the left main, which has a slightly curvy pattern. And in certain projections, it looks to have a disease, but when you image it, there isn't anything which requires treatment. So in case of ambiguity, it's very important that we use intracorneal imaging and a more physiological assessment. So, in some of these cases, for example, with this sort of orientation of the left main, you might have damping when you engage a catheter because the catheter might be at the roof of your left main, but it doesn't necessarily mean that you have a problem in the left main itself. So imaging really helps us to take an appropriate decision whether it's truly disease or there isn't a disease and it's purely an angle issue. This is the second patient. This patient presented with a high-risk anterior STEMI, occlusion very close to the ostium of the LAD, and the operator landed a stent in the emergent setting as close as he could to the left main, but sparing the left main. There was severe disease of the right coronary artery, which he also tackled as part of the original presentation. And the patient recovered and then came back on day 5 to have the left main looked into and treated appropriately. So this is the angiogram on day 5 after the patient having been treated for PCI for its STEMI. So angiographically, it looks 1-1-1. It looks like a true bifurcation. It looks big bifurcation. But however, when you image the ostium of so this is IVUS in the circumflex, and this is your wire in the LAD. And what you find is your luminal area is 9.55 in the circumflex, and the vessel is 12.3, which gives you vessel luminal loss of only 22%. So there isn't significant disease in the ostium of the left main, irrespective of what it looks in certain projections. However, if you just image it a couple of millimeters further down, you find where the vessel is more circular rather than ovoid or elliptical, your vessel diameter is around 18.8. And this gives us an impression that ostiums are not always circular. They can be elliptical or ovoid. It doesn't mean it is diseased. So in this particular patient, despite the angiographic projection, the patient does not have any significant disease in ostium of the circumflex. So what we did is we put one straight stent connecting the LAD stent into the left main, optimized the left main part. We opened up the struts, and this is imaging into the circumflex after the PCI has been performed. So again, you can, when you assess this, what you find is your vessel luminal diameter of the ostium of the circumflex is 8. So there has been a degree of carina shift, but however, it is still adequately sized by any criteria. If you still feel uncomfortable because of the visual appearance, you can assess this with physiology. And what we find in this particular patient is FFR of 0.92. So as Shripal has covered, and as we're all aware, as far as bifurcation goes, if you have a good result with physiological patency of your side branch, professional will always give you a better result compared to a complex strategy. So again, In cases of ambiguity and important decision-making which affects long-term outcomes in patients, intracoronary imaging along with physiology can help us guide our therapy appropriately. This is again an example of why we should consider imaging both the parent as well as the daughter vessel. So you have on the left-hand side essentially a distal left main bifurcation where angiographically it seems the circumflex seems to be more diseased. And when you IVUS the circumflex, this is an IVUS in the circumflex, and you have a fly-past view of the LAD, it looks pretty good. And you think, yeah, the LAD is good, we can probably, stent across the LAD. However, when you flip it across and you start imaging the LAD itself, you find there's a fair amount of positive remodeling of the vessel, there's a fair amount of fatty tissue and a degree of calcification. And the LAD ostium is much more diseased than what it meets the eyes if you just had a fly-past view. If you then flip it around, how you look into it, if anything, is more disease in the ostium of the LAD than you have in the ostium of the circumflex in this particular patient, irrespective of what the angiogram suggests. And this is another example of a large LAD diagonal bifurcation. Again, when you're doing IVUS in the LAD and you're doing a fly-past view of the diagonal, that looks perfectly good. But when you put the IVUS in the diagonal, you find that's not the case. It's a heavy plaque burden along with the degree of fibrocalcification. And this is an important side branch. So if the presentation of the patient allows you to image both the branches, where both the branches are significant, and you would like to preserve physiological patency, it's always suggestive and optimal that you image both the branches rather than deciding purely on a flyby view of the side branch. This is patient 3, a 70-year-old gentleman who was admitted with NSTEMI, not significant past medical history, mildly impaired LV function, low normal, and he was found to have a left main disease, which I'll just show in the next slide. And when you do the syntax too, it showed equipoise between PCI and bypass. So the patient opted for PCI, and this is projection angiograms. So this is a PA caudal view, which essentially shows a 1-1-1 bifurcation of the distal left main stem, which extends into both the daughter branches. This is an acute presentation. You do not know whether this is a soft plaque with a degree of thrombus or it's fibrocalcification until you started dealing with this patient. So once I passed the wire in the LAD, I realized this was all calcium and I had real difficulty, in fact, wiring the circumflex, and I had to finally use a Gaia 2, And I had to use a Gaia 2 wire, in fact, to gain access to the circumflex ostium and get into the main vessel. And this is my turnpike classic being rotated. This is a 7 French guide. This is a macrocatheter, which the design allows you to have a fair amount of push. And just trying to rotate this catheter, you are trying to push the guide out. So it was more calcific than I was hoping it will be. But obviously we knew that what we were dealing with at this point, that it was all calcification. The vessels did not allow any imaging up front, so we had to image, we had to pre-dilate slightly, and this is a 2.5 branch vessel, non-compliant balloon, which was burst in the circumflex ostium, and that allowed us to carry on imaging both the branches. So here we see the proximal part of the left main, a good quality vessel, which is just a fleck of calcium. This you have the distal left main stem after a degree of predilation with non-compliant balloons. You can see it's heavily calcific. You can see some breaks from the initial ballooning that has happened in the calcium. This is the ostium of the LAD, which again has a fair amount of fibrocalcification. And this is the ostium of the circumflex. So you can see the wire in the LAD here, and you can see the wire of the circumflex there. So essentially, as expected, heavy fibrocalcification in the distal left main stem extending in both the branches. So after having created some channel, we first tried to prepare the circumflex ostium. And this is the 3.5 angioscalp balloon after we used a 3 non-compliant balloon. And you see still is a degree of under expansion at the ostium of the circumflex. So we then upgraded and upscaled our calcium modification with a 3.5 millimeter shockwave balloon. And it essentially required 4 shocks for it to be fully expanded. So now you can see the area where you had under expansion in the score in the angioscalp now has complete expansion with the help of that shockwave balloon. So a shockwave balloon allows you to have delivered 8 shocks. So we used 4, so we used the other 4 to prepare the proximal LAD. and the LAD left main bifurcation, and then again further into the left main. So to prepare the LAD and the left main stem. So what we had in this patient was we had a true bifurcation 111, which was heavily calcific, and it had a wide angle. And obviously we heard some of the evidence behind left main bifurcation. So we opted for a DK crush, taking into consideration all these factors. I'll just take you through the steps. The first is you deploy the stent in the circumflex. You can see a balloon which is sitting in the left main stem. After this, once you have deployed the stent, you take an angiographic acquisition to make sure you're happy there isn't an edge dissection of the circumflex stent, that you don't want to post-dilate the circumflex stent before you crush it. So once you're happy that the circumflex part of the stent is optimal, then go on to crush that's the circumflex stent. Everyone has their practices. I usually pull the wire out from the circumflex, and I've always done that. So you've crushed it with the balloon which you had taken and was sitting in a LAD and left main. Then you go back with a larger balloon, because this first balloon is not big enough to crush it properly. And you can see this balloon is across the bifurcation, but the larger balloon is like a pot balloon, and you place it just proximal to your bifurcation. This allows you to crush the 2 layers of metal in the left main stem adequately, and you avoid the risk of when you rewire that you're not going through the 2 layers of stents. So you obviously then recross into the circumflex. You do your first kiss of your DK crush. Then you position your left main stem LAD stent, and this you see this wire technique which we were discussing before, where essentially I've put a wire in the coronary sinus, which helps me to have an idea where the coronary sinus is without contrast, and you push the guide forward till this wire in the coronary sinus starts to buckle, and you know you're trying to push it back into the left main and use of the guide, and that's how you position the ostial stent. In this particular patient, there wasn't disease in the ostium, so it wasn't that particularly relevant. But anyways, you've placed the stent in the left mains to LAD, then you pot it at 1:1, you recross, and you kiss. This is your second kiss of your DK crush, and you repot, and that's your the steps of you have for a DK crush. And these are the final results. This is the PA caudal projection, and this is your PA cranial projection. So patient 4, this is managing left main stent failure, because that's also we deal with nowadays more and more, because PCI to the left main has become not uncommon in the last decade. So this is a rather young patient, 56-year-old gentleman who had PCI to the left main and circumflex in 2013, and a culotte technique. We didn't have double kissing culotte around that time. Had recurrence, did pretty well, went 5 years, but then had recurrence of symptoms. Presented to a hospital in London, and they found that severe ISR in ostium in the proximal part of the circumflex, which was treated with cutting balloons, proper cutting balloons, so Wolverine, and a drug-eluting balloon, which was Magic Touch, which is a sirolimus eluting balloon. But however, then the patient represented to our hospital, because he had moved to our area within 4 months and had recurrence of symptoms in keeping with unstable angina. So having had the details from London, it seemed that very likely it was the same area, which is the circumflex ostium and proximal part, which we're looking at as a stent failure. And this is the angiogram of that particular patient. So it's a left dominant system. And you can see that the left main and the LAD part of the stent, which is now 6 years old, still looks pretty good, but you have severe re-ISR of the stent in the circumflex, which extends from the ostium of the circumflex into the circumflex for a good 10 millimeters. So we create a bit of space with a 3 millimeter non-compliant balloon, and that's the first balloon I took, because this is ISR. It's usually slippery material, and the large balloons go through much easily. So 3.5 non-compliant to create room, and then we image it. And what we find is in one wall of the vessel, there is a big shelf of calcium, which obviously constrains the expansion of the stent. And further downstream, you essentially have soft material, which is neoatherosclerosis. And you go further downstream to have an idea of the vessel size. So what we found is the vessel should be around 4 millimeters where the stent has been deployed, and it was a 3.5 millimeter stent. And the DV used was also a 3.5 millimeter DV. So the mechanism of stent failure in this complex left main stem PCI. It is a late failure, but the mechanism is mostly neoatheroma progression in an undersized stent, which has a degree of underexpansion in the proximal segment because of fibrocalcification. So we have to understand why the stent has failed, because this is an important territory. This is a stent failure, so we have to get it right as much as we can, so that this, the repeat PCI has longer term results, at least to our best of our ability. So what we did is we didn't feel that we can land a stent in the ostium of the circumflex, because that's where the problem was, and you can't miss it again. So in an effort to modify the substrate of the underexpansion and the mechanism of ISR and neoatherosclerosis, we went forward and used a foam limited shockwave balloon, so 1-to-1 vessel sizing. And again, this is at the fourth shock, when the fourth shock is delivered, that we were happy with the expansion of that balloon. This can also be done with laser, and laser also does a great job in debulking and also modifying any fibrocalcification behind the stent. So you can use either of the two that you wish to, whatever you have on the shelf. And once we had done that, and then what we decided is we could not land the stent because of the angle. For a left main, if you see at the top left corner, is a relatively shallower bifurcation for a left main. So we didn't feel that we can nail the ostium of the circumflex without protruding back into the left main. And to keep life simple, we just used a 4mm ultra-thin strut stent from the circumflex into the left main, and then we proceeded to kissing balloon with a DEB 3.5mm EB in the LAD and a 4mm non-compliant in the circumflex system. And this is the final result of this particular patient. And I'm pleased to say there's been 2 years since, and he has remained well. And this is the post-PCI IVUS. If you have done IVUS before, it makes sense to do it again, because if you're not happy, you still have the opportunity to do things if the scope remains. So this is, again, the ostium of the circumflex. It's elliptical or ovoid. It is not a circular ostium, as I've mentioned before, but just 0.5 millimeter, 1 millimeter further downstream, when you look into the vessel, this is now a circular vessel. So we have managed to modify the shelf of calcium and have a circular stent rather than so-called a D-shaped stent. And this is further downstream how the stent looks like. So that was satisfactory IVUS post-PCI, and we did whatever we could to have as optimal a result in a patient who had 2 recurrences of ISR or stent failure in a critical area of the left main stem. This is patient 5, a 62-year-old gentleman who had an anterior end STEMI while holidaying in South Wales, was just treated for hypertension. Admission cholesterol was 2.4, which I think in India would be, I don't know, maybe 250 or something like that, if you're looking at the conversion. Mildly impaired LV with anterior hypokinesis and otherwise reassuring other blood results. And this is, the picture. So the operator or the trainee decided to go with a guide of the left system, having shot a reassuring right side. And you essentially have a disease in the proximal LAD. You might say ostial because it's within the 5 millimeters. And as they were taking more pictures, this is what happened. And I think they probably didn't appreciate, what has happened, because there were 3 more further acquisitions following that, the one at the top. And obviously things got worse and worse. And at that point, we had a very senior nurse, a cath lab sister, who advised maybe they should ask for a second opinion and help. And I was called from the other lab. So when I joined and I saw the pictures, obviously this was contrast-induced dissection, because how the guide was sitting in the roof of the left main stem. And when you have this situation where you have extensive dissection of your entire left system, it's imperative you try not to inject anymore till you have stents in situ. So you wire the vessel with a non-polymer jacketed wire, if in general, your workhorse wire, and entirely by feel, trying to be happy that the wire passage is as you would expect. This is a wire passage which probably went into the diagonal when I was making that wire passage. And then you put a wire in the circumflex, and before you inject or anything, you confirm your wire positions with IVUS. So this is an IVUS on the LED wire. and I've got 2 wires, one in the LAD and one in the circumflex. And this is IVUS. I've kept the entire run because it's, I think it was quite educational. So this is IVUS in beyond the medial AD, and you can see this is, disease-free vessel, good quality vessel, good size. And as you are now coming in, you start seeing between so this is now entirely false lumen, and your IVUS catheter is essentially scaffolding the true lumen. So you had extensive compression of the true lumen right from the medial AD onwards. So this is all contrast of blood, combination of the two. You can see this compression even within the true lumen because of what has happened because of the injection. And now you're slowly moving towards your proximal LAD. This is probably a branch which came out, maybe a diagonal or a septal. So it's again suggesting that wire was in the true lumen. And as you come more and more proximally, you can see that the true lumen becomes smaller and smaller. And essentially the false lumen is much larger. And it really helps because it's told us we are in true lumen all through till now. And the wire is not true, false, true. And now you can see the circumflex ostium coming here, and this is your circumflex wire. And this is very reassuring to see because now both your wires are in the true lumen, at least in the left main stem. You still IVUS the circumflex despite this appearance because at the proximal part of the circumflex, your wire is in the right place, but you do not know whether the wire has exited the true lumen further downstream. With a normal non-polymer jacketed wire, that very rarely happens, but it can happen. So we imaged that circ as well. And then I had in fact fixed the medial AD first to gain some sort of a position and control. And then it was positioning of the circumflex stent. So we essentially had a situation where we did not want to lose our wire position. So we decided to go forward with the reverse T technology, not something that you do routinely in left main bifurcations, but given the situation and the time pressures and how the patient was, we felt that was probably the safest of all the techniques to proceed and finish the procedure. So that was a little bit of contrast to make sure you're happy with the positioning of the circumflex stent. And again, this is a little bit of contrast for the ostium of the left main stem. But as I've shown and we have discussed before, you can avoid this contrast if you have a floating wire in the sinus of the left main stem. So those were the 2 little puffs of contrast that we used to position the stents. You should always spot because the stent is never opposed in the left main, which is going back into the LAD. And once you have done that, if time allows, recross and kiss. And this was the final image of this particular patient. In the cranial view, you can see hematoma beyond the stent. You can see hematoma in the diagonal. And this will happen. So when you're placing your first stent, always go long, go beyond where the hematoma is by a good 5 to 10 millimeters. Because otherwise you squeeze the hematoma distally and you might be chasing that hematoma up to the apex. So going long beyond where you had the hematoma on IVUS. And you start distally and you come back proximally. And this was the appearance in the PA caudal view. So there was hematoma in all the branches as expected, but the patient did well. In fact, came back on day 5 and still showed hematoma as expected on imaging. So to conclude, I think understanding of the outcomes of the left main PCI is crucial for consideration of planning of left main stem PCI. A provisional approach where appropriate is always preferable. And this should be undertaken while maintaining physiological patency of the side branch, which for the left main most of the time is your circumflex branch. Imaging and physiology can help take appropriate decision. At times you might think there is a problem, but imaging tells you there isn't a problem, and it's a 2D angiogram showing you something which does not exist within the vessel architecture. It also helps us to decide on provisional or two-step technology and techniques, especially when it seems there is disease around the left main distal bifurcation. I personally think you need a degree of expertise in various forms of two-step strategies to help tailor PCI depending on the clinical presentation and individual anatomy. It's fantastic, and I understand that you get good in one, but if you have to tailor treatment depending upon presentations, depending upon anatomy, I don't think one technique suits all patients. And I think over time, you have to develop an expertise in various forms of these two-stent strategies. If you have to do the job as good as it can be done. In certain situations, you may not be able to image upfront before you stent because of hemodynamic instability, etc., etc. But I personally feel it's mandatory that you image after the stent has been deployed, because by that time, usually you're in a stable situation for the patient. It helps us to optimize the stent. We have very strong evidence nowadays of minimal stent area, about stent apposition, which helps us to get the best possible long-term outcomes in this crucial anatomy. So even if you can't image upfront, I feel you should image at least at the end of your PCI. So thank you.
Excellent, excellent presentation, excellent cases, all 5 cases. Just curious to know that you said there is still a hematoma existing there beyond this 10. So did you follow up with this patient with the angiography or?
For this particular patient, no, but I have had done in other patients and had done inpatient angiograms up to day 7. They still remain. So
okay.
If you have hematoma, especially if it was a proximal vessel hematoma, I think probably you're better off not cathing them too early. If you have concerns about vessel patency distally, you can keep them on a GTN infusion for 24 to 48 hours. And once you've passed that time frame, your vessel very rarely will occlude. I had brought them back at 6 weeks, and 6 weeks there's complete resolution. And when you do an OCT, it's nothing there. It's complete, resolution. If you feel that the vessel, you're not sure of your stent sizing, because it's very hard to have a vessel diameter with that degree of hematoma, because there's nothing called a true vessel diameter anymore. And if you're not happy, and you can bring them back after 4 weeks or something, re-image it, and if you find their stents which are hanging or not opposed, you optimize them. So that's an option, especially if it's very proximal vessel PCI in the setting of significant hematoma.
Excellent, excellent comments. Any of the panelists would like to ask any questions? Dr. Kandur, Dr. Joan Pinto. So thank you very much for your excellent presentation. All 5 cases, super duper cases. Now I can call for the next speaker, Dr. Ashok Kandur. Dr. Kandur?
Yes, sir. I'm here. Just morning, Dr. Bang, and so far excellent presentations. Can you hear me clearly?
Absolutely. We can see you clearly. We can hear you, and your slides are also seen very well.
Okay. Thank you. So far excellent presentations, and thank you for giving this opportunity to present this topic, and most volatile and also complex topic, calcified left main lesions. So with that, this is my case like last week. So ostial LAD and also the left main extending into the left main, healthy circ vessel. So how do we approach? So with that, there's another second case, ostial left main case. Just so calcium mainly does poses safety issues, efficiency, and optical mechanical issues. When there is a lot of calcium, it poses a lot of major complications, dissections, perforations, and prohibits lesion preparation, stent delivery, and causes damage to stent studs and drug coating, and also does the stent expansion, minimizes, appropriate stent expansion is going to be limited. So these are the goals in the left main PCI lesions. If we want to modify the calcium, we need to avoid or ride through this kind of roadblocks. So severely calcified lesions increases safety risk and stent deliverability, prevents stent expansion, results in stent thrombosis. So we need to, how we can modify this calcium to avoid stent malapposition and safe delivery of the stents without any damage, and also avoid complications like a dissection perforations. So calcific nodules, this is IVUS imaging when we do without vessel prep, and it gives us asymmetrical stent expansion. Is an IVUS imaging, is a full arc of calcium, and this kind of lesions we deploy without vessel prep. There is a 50% underexpanded stents will be resulted. So impact of coronary calcium and different types of calcium in IVUS and characteristics. If you go into fibrotic calcific plaques versus heavily calcified hypoechogenic, if you look at the compliance of the vessel, that dictates character of the calcium, like a concentric, eccentric, or nodules that pose a lot of technical difficulties as well as the outcomes. If you look at the impact of the coronary calcium and in outcomes, pooled analysis from Horizons AMI and Acuity trials, death, MACE events that include MI, TLRs, and MACE events. And if you look at no calcium to mild to moderate, and severe, and it does result in higher MACE events and death and cardiac death from the calcium. So if you look at the calcium lesion assessment, imaging, as we mentioned earlier topics, is very important, and they've been insisted again and again before we do any kind of, if you see any calcium in the fluoroscopy, it is better to do the image guided stenting. First, to assess the anatomy and what type of calcium, arc of calcium, is a calcified, concentric, or eccentric calcium. So image is very important, either high definition IVUS or could be OCT. So whatever the lab does have a capability to do, it is better to use the image guided all the time. Approach, how can we approach this complex calcified left main lesions? Like a traditional practice of old traditional practice of high pressure non-compliant balloons, cutting balloons, like cutting flexitone, angiospore, and or move towards the rotational atherectomies, like rotational orbital laser atherectomies, or new advancements in like a lithotripsy, IVL, coronary IVL. So how do we approach these lesions safely, and we can achieve the stent expansion, minimize the complications? So if you look at the traditional practices like a cutting balloon, scoring balloon, the one live case was presented, they used the scoring balloon, and what are the safety issues with the scoring balloons, particularly when you use in the aorto-osteal lesions and cusp dissections. So we need to be a little bit cognizant in this kind of scenarios. Cutting balloons does like a longitudinal cracks in the calcium, in the particularly fibrocalcific tissue. Controlled expansion with the scoring balloon, and non-compliant balloons is a twin layer balloon designed with high pressure inflations. So you can always use the traditional practice of this before we move on to a little bit high risk high risk atherectomy devices, the rotational or orbital devices. So if you look at the traditional practice of high pressure balloon inflations, high pressure balloon inflations preferentially is stay away from the calcium and have a limited effect on the eccentric calcium, and does result in the perforation, dissection, and typically they don't modify very thick calcium. If you look at the cross-sectional view, so basically it's confined to where the compliance of the vessel, and if it's non-compliant in the area and the deeper calciums, it won't do good expansion or create cracks in the calcium platform. So this is the case-based approach. This is the patient with left main and osteal LAD, CTO circ, and using a 1.5 rota burr and debulking and using a rota burr for the calcium modification before we proceed to the stent implantation. Rotational atherectomy employs concentric advancing in the forward direction. You cannot do backward cut. And ablation of the inelastic fibrocalcific plaque, sparing adjacent elastic vessel tissue. And limitations of rotational atherectomy depends on the calcium eccentricity, luminal area, burr size, and degree of wire bias. So these are the limitations. And also, as per FDA, it's not indicated for the calcium modification. The initial indications were for the fibrocalcific plaque modifications. Fibrocalcific, not calcium, like fibrous lesions. So if you take another orbital atherectomy catheter, like a Diamondback and a CSI, and simple device setup, and you can do backward as well as a forward cutting on the calcium because of the burr design and easy setup. And you can see the rotational atherectomy, the physiology principles of orbital versus rotational atherectomy, and difference between the rota versus CSI. If you see the concentric versus the shaving the mechanics of the rotational versus orbital atherectomy. And this is my case I just did last week. It's an osteal LAD, 89-year-old, heavily calcified osteal lesion. And so I decided to do with the CSI. And I don't want to do forward cutting. I just did a glide assist feature on it and did a backward cutting and stick to the single stent technique. With the impella assisted protected left main PCI. She's 80-year-old. I just stick to this single vessel stent. So the technique I used in that case was after crossing, I used the glide assist and I did a backward cutting of the calcium. And it is useful, this kind of platform like orbital atherectomy, if it's too tight to cross the wedge nose cone in the lesion to restrict orbit. And also you can minimize jumping and no dissections because you're doing it backward. And also when you cut, you need to do slow traverse speed is a key. And also the position of the viper wire selection is also very important when we do the orbital atherectomy. So you can position of the wire dictates your wire. The viper wire does have a graded weights along the from center to distal portions of the wire. So position dictates the geometry of the vessels, whether you're doing a forward advancements or like a backward withdrawing or cutting in the backward direction. So wire position is very important when you do the backward cutting. So also when you do CSI atherectomy, you need to avoid forward jumping. So you need to go very slow and not to go so fast and try to avoid jumping. So if you look at the coronary orbital atherectomy for aorto-osteal lesions outcomes, and if you look at the perforations with this device is, even though it is not indicated for the osteal calcium modification, not FDA approved, but we still use it. And if you can see the perforations, tamponade dissection, no reflow phenomena are very minimal compared to even non-osteal lesions. And even though its p-value is not significant, so it's a feasible and safe treatment option for the calcified aorto-osteal coronary lesions. And as we presented in the live case today. The other modality, armamentarium, just came into our hands was like 2-3 years ago, like a coronary intravascular erythrotripsy, very safe, and you don't need to use the ping pong technique. If you have a bifurcation lesions, sleeve technique, or like Shripal prior demonstrated case-based approach, like a 2 guide catheters and with the sleeve technique. So you can save the side branch with even 1 catheter, and it does intimal and medial calcium modification and easy profile, and it is a very safe therapeutic option for the calcium modification intravascular lithotripsy. So you can look at it. There is no requirement for the specialized wire. You can use your own workhorse wire, like your Pro Water, BMW, shock wave passes through the plaque and vessel, enabling modified intima and as well as the medial calcium, and also reduces the risk of dysembolization, because disrupted calcium remains in the vessel wall, so reduces the dysembolization. And also the lithotripsy allows low pressure balloon, avoiding the risk of dissections, and also the by going high pressure. And also you're able to protect the side branch with the second wire, so it don't prohibit you leaving the side branch wire in place. Compared to rota and you can either CSI, you need to either follow the sleeve technique model or ping pong two catheter guide catheter model, or you need to take a take the wire out and hoping that side branch is not going to plaque shift or dysembolization to the side branch, so that you can avoid leaving the wire, your workhorse wire, what you do. If you look at the types of lesions you can use, I mean, you can use this IVL, coronary IVL lithotripsy balloons in the ostium. You can do in the bifurcation lesions, and you can pretty much it can give a 8 treatment 8 treatment zones, so you can always use, I mean, left main, LAD, and the CERT with the one balloon most of the time is adequate enough to treat all the territories. So is like 7 French sheath, yeah, the patient we use for 7 French sheath and extra EVU catheter, and lesion prep need to be done with a non-compliant balloon, low pressure, before you place a lithotripsy balloon. So we use either 2.0, 2.5 up to 3, depends on the size vessel. And you prep the vessel, then you place the lithotripsy balloon, and then for the shockwave lithotripsy balloon, and we place the 2 overlapping stents, and followed by post dilations. So other concept of rotatripsy. So we have this is one of my colleagues' pictures shared from the industry. So it's a baseline LAD, heavily calcified, and try to do non-compliant balloon. You can see the dog bone and unable to expand it, and then try to use the rota burr for the under expansion of the stent, and they want to do it. And post rota, still you have balloon is not expanding, then move to a concept of rotatripsy. So we did a non-compliant balloon, followed by rotablator, followed by IVL. But then you can see how smoothly and yielded the stent, under-expanded stent, and you can see the change of the medial calcification. And this is the post lithotripsy and pre-dilatation and post-dilatation, nicely expanded stents. This is the final picture. You can see the post rotaburr, shock wave, and if you look at the iris picture, well expanded stent. So what is the algorithm? So when you take an algorithm, our traditional practice is we want to keep the procedure simple. We always try with the NC balloon. If the calcium is not that heavily shown in the fluoroscopy, and then we always, if the calcium is too high grade calcium, too much, then you always use the kind of either a rotational or orbital atherectomy and our scoring balloons. And then if it is not yielded, then other thing is safest approach is you don't need to deal with the side branch protection, everything. You can use safely IVL, coronary lithotripsy shockwave balloon, and it will help you for the high risk patients. Thick and deeper calcium, you can use a left main, ostial bifurcations as mentioned. So it's a very safest therapy that is available, and without much technical learning curve. So the key step in the is imaging. And then you can say the if it is a calcium is only mild to moderate, you can always try. If you don't have a equipment in your armamentarium, you can use the NC balloon 1:1. Always size it, and is well expanded. You can always move forward to the stenting and image guide optimization. If it is underexpanded and having a dark bone balloon is behaving, then always you can use the rotational or orbital atherectomies if it is underexpanded, or you can do IVL, or you can go to the directly to the lithotripsy shockwave balloons. You can look at the differences between the rotational atherectomy and orbital atherectomy. If you look at the rotational atherectomy is unidirectional, and orbital, that is a CSI, is a bidirectional and is a concentric, and it is that burr based. If you want to use, and you sometimes if your vessel size is higher, you might need to escalate your rota burr to 1.5 and higher. And but here the only one but you can use 1.25 and eccentrically mounted and centrifugal force, and while doing the cutting the calcium, and allows the continuous flow of the blood and saline during the while you're spinning. So then compared to lithotripsy and orbital atherectomy, lithotripsy balloon designed to modify calcium without atherectomy. It cracks the intimal and medial calcium without removing the calcium, and no distal embolization, and but need further data to support TLR and instant restenosis and DES effectiveness without atherectomy. And if you compare CSI is a bidirectional and differential cutting, and you do have some studies to back up the MACE events, TLRs and ISRs, and effectiveness with in the setting of drug-eluting stents. This is the lesion preparation percutaneous intervention with rotational atherectomy. See the OCT guided images versus orbital atherectomy, and you can see the lithotripsy. You can see the calcium platform, how the calcium is modified and allows you to the adequate expansion. It's a different OCT images of comparing the rota, orbital, and also the intravascular atherectomy. So this is my slide, how to approach the algorithms, heavily calcified coronary lesions. Most important thing is everybody is pointed out, imaging is the key to define the calcium, whether deep calcium, superficial or nodular. And if the deep calcium is there, you can always try scoring, cutting balloon, lesion prep. And if you see the adequate expansion, you can do the stent and OCT and IVUS post-stent expansion to make sure stent is adequately expanded. And if it's a superficial calcium, moderate to severe, balloon is crossable. You can use the lithotripsy, orbital or rotational atherectomy. Balloon is uncrossable, and you can use the directly to the rotational burr or orbital atherectomy, that is CSI. Always reiterating, imaging is key portion in this kind of to reduce the MACE events, cardiac death, and mortality. Conclusions: coronary calcium continues to increase in prevalence in parallel with the aging patient population, and also rising rates of diabetes and renal disease. And calcified coronary lesions remains a persistent challenge in our present day-to-day interventional practice. No more we see like a type A or type B lesions. And imaging is to strategic treatment algorithm is critical for the optimal patient management. And new device technologies are increasingly facilitate more complete and effective revascularization with superior short-term procedure results and long-term procedure outcomes. Thank you.
Yeah. Thank you. Great talk. Can I ask you one question?
Sure, Dr. Chaudhary.
Yeah, so we are just about having orbital atherectomy in UK. And obviously we have lithotripsy for a good few years now, and as well as conventional rotablation. So what are the worries if you are taking on orbital atherectomy? What are the factors that we need to be conscious about, because for me it seems in a way orbital atherectomy might bridge the gap between a conventional rotational atherectomy and lithotripsy, because if it's a large vessel, often rotablation on its own is not adequate because it doesn't touch the so-called superficial calcium, which shockwave does. But orbital atherectomy, in a way, one simple gadget can take care of very tight lesions, but also debulk enough where you may not require a lithotripsy balloon after that. Is that the right understanding?
Yeah. So as you rightly mentioned, if you use the traditional rota, because of the size of the vessel, you need to size it to the vessel, and also it changes your guide catheter size and everything. So the CSI, the orbital atherectomy wise, is only 1/1.25 because of the differential cutting, and so you're able to, modify the calcium. So for the, on contrast, the lithotripsy, and they have different sizes. So you're able to achieve what 1:1 sizing. We can modify the calcium.
Excellent. Is it dangerous with regards to slow flow? Because in a way you think it will debulk more than a conventional atherectomy. So does it cause more slow flow phenomena or more perforations?
Which therapy you're talking about?
The orbital.
Orbital.
Rotational?
Orbital. CSI.
Rotational atherectomy? Was that CSI? Okay, CSI. So orbital. Sorry, it was not clear. So I do a lot of, like, I used to use a rota a lot, and then we moved to because of the easy setup, and we're training the fellows in the CSI. And because of the microns, when you spin it in like a very low particle distal embolization, I did not see any kind of, so far. I have only 2 cases. I do a lot of CSI coronaries, and only 2 cases I had a no reflow phenomenon in the LED. And perforations, yes, I had one perforation that was 2 weeks ago, and it was heavily calcified, and stent was not, balloon was not adequately expanding. I took a high speed RPM and I did a 4 or 5 cuts, and it is a contained perforation. Yes, 100%. When the minute we increase the speed from low to the traditional RPM to high RPM in orbital atherectomy, because it increases the thermal energy, and it spins your blood particles, RBC, and it does cause a no reflow phenomenon, as well as the higher speed does pose perforations too.
Excellent talk. You covered virtually all the calcium debulking tools in entire range, including the one with the rotatripsy that sometimes we need to use in given case where there is a tight lesion and you are unable to pass the lithotripsy balloon. You can do a rota and then cut the deeper calcium using lithotripsy. I think it's a great number of tools that we have available now, particularly for calcium, is I think phenomenal. Particularly lithotripsy found to be very safe, does not have any problem. But there is a report of occasional perforation with the lithotripsy. I think lithotripsy, Anirban, you have a larger experience. UK, it came very early actually, and USA, the FDA approval came now, only recently.
Correct.
So,
yeah, I guess, the perforations happen not essentially because of the kit. You can make it perforate how you use the kit, as you're saying, lower speed, higher speed. But perforations typically happens because of the substrate. And it typically happens when you have deployed the stent, or more often when you're post-dilating the stent. It's very rarely when you've used the gadget. If I had to pick one which potentially can cause the most dramatic perforation while using the gadget, it's still going to be lithotripsy, because you're sizing a balloon 1:1.
That's what I was saying.
But your rotablation or your orbital atherectomy is much smaller than your vessel size. And in those 2 settings, it's usually the post-dilatation where you have your problems. But in lithotripsy, you can have the problem while you're preparing with the balloon.
And which tool do you use for nodule? Calcific nodule?
The calcific nodule, there is some evidence coming that lithotripsy might work in calcific nodules. We just have to see whether that's the case, because in general, the technology works with the reflection of sound waves. So if you do not have calcium on both sides of the vessel, the sound will not be reflected. So, the thought is you might have to, deliver more runs of shocks where the nodule is for it to work, because the reflection is not happening. So for calcific nodule, I think some sort of atherectomy is definitely works, because it's going to shave. If it's a really big left main, then your conventional rotablation may or may not do it. And if you want to shave it, what I try to do is reduce the burr speed so the burr wobbles. So and so it touches. All you want is essentially shave off that top of the hill. But I guess in orbital, the technology renders itself a shaving of the nodules. Obviously, I don't have experience with all.
But as far as I understand, in orbital, in the nodule, orbital is not often used. It's a rotational atherectomy that is used. But the problem is wire bias. Wire bias may not allow the shaving of the nodule, but for that you have to push wire while doing the rotational atherectomy, while doing it. So pull the wire while you are, taking the burr front, slowly put it for front and pull the wire, release the brake and pull the wire in and out so that wire bias doesn't occur. And it allows to shave the nodule. So that's one factor that is very important, because if we use rotational atherectomy, then that is the concern that it may not really shave the nodule due to wire bias.
Yeah, you're right, Dr. Bang, I think.
Go ahead. And another thing that I heard, I don't know, I want to know from all of you, that lithotripsy balloon per se is not very useful in nodule, because it can puncture the lithotripsy balloon. That is one danger. Second, usually when there is this high pressure puncture while doing it, it may cause the dissection of the vessel down below. So these are some of the concerns that most of the techniques have, these concerns. So what is your take on that?
So we use mostly when you see nodule in the imaging, we always use either rota or CSI. So we don't go in the direction of the even for the non-compliant or lithotripsy balloon. We always stick to the rota or rotational. Orbital atherectomy, and we do like a backward. The rotational, orbital atherectomy, I can cut from front and back. So without adjusting the much wire position, but rota, you need to, as you rightly said, we need to change the wire positions.
There's one question for you, Dr. Ashok Kondur.
Yes, sir.
Which you prefer in LMCA imaging, OCT or IVUS?
IVUS, because of particularly being like most of the time you see very short left mains, and if it is the bifurcation, I do IVUS. If it is a main body and ostium, bifurcation, I do OCT, and if it is a main body or osteal lesions, I stick to the IVUS. Fair. Because of the displacing the column with the OCT is very difficult, and the images will be not clear. So we do move forward. We do the traditional IVUS for the ostium and mid body.
So thank you very much. Excellent talk. Any further comment? May I call on Dr. Dion Pinto? Is he available there? Dion?
I think so.
I can see him. I think he must have gone in the room somewhere, but I can see his video being on. Dion Pinto? Dion? Is he there? He's there.
Yeah, he's here, big boss.
Yeah, we are waiting for your talk now. So looking forward to you talking on how to prevent and treat osteal LCX coming back post LMCA PCI. Current approach.
All right. Sorry I'm late. I was doing the TAVR.
Right. So this is your cath lab area, or you're in your office now?
Yeah, no, I'm in the control booth of the cath lab.
Okay.
Okay. How does it look? You see the
very
slides?
good. Your slides are very
Okay.
clear. You are seen very well, and I can hear you also.
Okay. So, this talk is actually made much easier by the previous speakers because everything I'm going to say, they already have said. The importance of a number of things, including imaging, lesion preparation, as well as some of the considerations for the left main. So I'm going to highlight some of these points, as well as maybe some additional factors to think about. But Ashok and Dr. Chowdhury and Sripal and the others have already made these points. But when we think about the circumflex, we think of it as a special bifurcation. In many cases, we're worried about the circumflex, maybe unnaturally so, because we would have no problem going across a diagonal branch and doing a provisional approach. But for some reason, when the side branch is the circumflex, we get very much agitated. But nonetheless, malapposition, protrusion of the strut into the aorta, a medial tear, more than for one stent strategy, struts crossing an osteal side branch, or for two stent strategy, struts crossing the osteal side branch, uncovered struts. Obviously, infection and inflammation are risk factors in the circumflex for restenosis. But why is the circumflex special as a side branch that we deal with? Well, I would say that the major risk factor, first of all, for circ restenosis is us. And the fact that in the United States, at least, less than 10% of cases involve intravascular imaging. I think we're doing a deficient job in understanding what the problems are and how to treat these lesions effectively. Other factors for restenosis in the circ you're well aware of and have been mentioned earlier. Distal left main lesion, two vessel stenting. We'll talk about the carinal angle. And then from a technical standpoint, when there's excessive tortuosity, wiring the circumflex or rewiring, recrossing with stents or other devices, positioning the stent. And then there's also, because of tortuosity, risk of proximal or distal edge dissections, either with the balloon or stents. And then because of calcification or the lesion being fibrotic in the osteal position, there's recoil and underexpansion as a risk. So all of us are aware of this picture from S.J. Park, looking at what we should be trying to achieve as optimal results in bifurcation stenting with the LAD of 6, the circumflex ostium of 5 millimeters, and the left main of approximately 8 millimeters. This is obviously predicated on the fact that we have to image in order to know what the size of our stents are. I think Dr. Chowdhury also mentioned, or perhaps another speaker, that when you IVUS these limbs, you can get, if you're trying to look at the side street from the main street, you get an oblong view of the vessel, and you may either overestimate or underestimate the amount of plaque or what your lumen area is. You have to IVUS these limbs individually, either pre-procedure, post-procedure, or preferably both. And then Sripal talked about some of the earlier studies looking at the risk of 2 stent strategies and 1 stent strategies. But many of these procedures were done with early generation stents, or in some cases, bare metal stents. And you can see here that the pattern of restenosis and the time course of restenosis is different when we look at drug-eluting stents and bare metal stents. And we could also even replace this column with first-generation stents versus drug-eluting stents. The time course, the appearance of the plaques, and the presence of neoatherosclerosis, as was mentioned by Dr. Chowdhury, is relatively frequent with our drug-eluting stents. And this we'll get into when we talk about the treatment of osteal restenosis. So here is some direction from the European Bifurcation Club, some general issues of how to approach the procedure, which is, as have been mentioned throughout the talks this afternoon for you and morning here, is a meticulous lesion preparation, imaging, and then the stent techniques we'll talk about, final kissing balloon inflations at high pressure, with sequential high pressure inflation followed by simultaneous inflation. POT, as mentioned, and as was also mentioned, perhaps fractional flow reserve to know which types of lesions need to be treated and which do not. So as has been talked about, imaging and physiology, imaging to understand what we're treating, physiology to know whether we should treat, the angiographic appearance of an osteal stenosis, which in many cases, as was mentioned, may not actually be a physiologically relevant stenosis. And then very important, lesion preparation, predilation. You saw cases with intravascular lithotripsy and atherectomy. I mentioned physiology. As you know, the angiogram can be very deceptive for us. And amongst many lesions now, this is not necessarily only the left main, but around 75% stenoses on angiogram, only 20 out of 73 were functionally significant. So obviously, ischemia in the moment, we can detect by physiology, and then risk for restenosis is perhaps a different problem that we're thinking about. So as Sripal showed earlier, the DK Crush 3 study, randomized comparison of DK Crush versus culotte stenting. The in-stent restenosis were mostly located at the ostium of the circumflex, but TVR at the circumflex was very infrequent with this strategy. I mentioned, and as was mentioned, the development of neoatherosclerosis, very different than neointimal proliferation seen with bare metal stents. And these obviously may be more calcified or more prone to malapposition or underexpansion, what you see here. And when we look at either on OCT or on intravascular imaging, you see OCT, as was mentioned earlier too, the resolution is much higher. We can see the stent struts more individually, just a easier to interpret picture from my estimation. But underexpansion is defined as an MLA less than 70% compared to the reference. And it's present in almost 1/3 of cases of in-stent restenosis. So the only way to really define whether we are seeing malapposition or underexpansion is to image the coronary vessel. So I showed you this picture earlier, but to the right are some factors from the paper to consider. That ISR, any location with underexpansion, was far more prevalent comparatively. So almost a 5-fold increase if there was underexpansion. The 2-year MACE-free survival was significantly lower with underexpansion. And post-stenting underexpansion was an independent predictor, almost a 6-fold increase for major adverse cardiac events. And this is amongst patients getting stents. So I think that we have to do a better job at stenting and lesion preparation to have better outcomes. And that's why I said that our major predictor for adverse events in the circumflex is us, because we know this and we have the tools available to us. Now we can go overboard also. So my previous colleagues, Dr. Kuntz and Dr. Bain, engender the idea of bigger is better, that something that we all take as a a tenet of interventional cardiology dating back from this paper in 1992, that acute lumen diameter determines restenosis after atherectomy or stenting. However, bigger can become badder with stent hyperexpansion. So if we overdilate stents, as was mentioned, we get carinal shift, perhaps plaque shift less frequently, and then more target vessel side branch occlusion. That's the acute vessel occlusion. But even if we are using a provisional approach, it stands to reason that if you have partial side branch occlusion that we're leaving behind, even in the setting of no flow, that perhaps there's more TLR. If we look at the changes in the circ ostium after left main LAD stenting, 78% show a greater than 10% reduction in the minimum lumen area in the circ ostium after crossover stenting with the provisional approach. Carinal shift is the primary mechanism of ostial lumen loss, so the more deformation of the carina, perhaps with the larger the stent is, then you get greater lumen loss. Plaque redistribution or plaque prolapse, which is what we often say, is present in fewer than half of the lesions. So the risk factors obviously are narrow carinal angle between the LAD and the circ, and a wide carinal angle between the circ and the left main, because more deformation leads to more problems. So what are our options if restenosis does occur? We're limited in the United States with the absence of drug-coated balloons. These are experimental and in study right now, but the variety of other devices are well known to us and throughout the world. Drug-eluting stents with neointimal proliferation, laser is preferred. Stent fracture, restenting. Undersized stents, we need to deal with the reason for underexpansion, perhaps fibrosis, calcium. This involves either atherectomy or high pressure balloons, scoring balloons. Underexpansion, and also high pressure ballooning, scoring balloons, laser, atherectomy. 2 layers of stent, it's frankly malpractice to put in another layer of stent after that. We need to modify the plaque and make sure that we can expand the stents appropriately. And outside of the United States, I'm sure you're much more familiar than me with the utilization of drug-coated balloons. So looking at the clinical and procedural aspects from the Milan and New York Tokyo registry, if you're dealing with restenosis in the ostium of the circumflex, it's very common, more common with the 2-stent strategy versus a single stent strategy. But I think you can appreciate in a registry that different patients are selected for 2-stent strategies compared with 1-stent strategy. So thus, whether the increased risk of restenosis with 2 stents is due to technique or the fact that the patients have more complex disease, that remains to be determined. Drug-eluting stents are more effective than balloon angioplasty for the treatment of unprotected left mains with DES-ISR. A comparison with drug-eluting balloons is necessary. And then one thing I think that we should do as a thought experiment as interventional cardiologists is the consideration of the failure mode of what we consider the side branch when we approach distal bifurcation in the left main. If we know that the circumflex is the, quote, weak link, it's often the more angulated segment, the more tortuous segment, the more diseased segment. It's the osteal segment that we're dealing with in the bifurcation in addition to the left main. If we know that that is the weak link, perhaps we want to think of the LAD as the side branch and get the best result that we can for the, quote, main branch. Now, this is also partially thinking about down the line, what can we do when the side branch restenoses? If the LAD restenoses, we actually have a treatment that's perhaps the same or better than the initial drug-eluting stent, and that's the LEMA. If we think about the circumflex restenosing, we're not going to be sending that person for bypass surgery if the left main and the LAD are open. So perhaps when we think about the DK crush, we want to treat the LAD first as the side branch in the nano crush or the DK crush, and then stent the left main into the circumflex, getting as smooth and less turbulent flow and less metal in the ostium of the circumflex as possible. I'll finish with a couple cases. There's a 74-year-old man post-CABG. He was 13 months post-circumflex angioplasty alone for 2 layers of non-expandable stent. He had recurrent chest pain and lateral ischemia. So a 1.4 laser would not cross. That's my preferred atherectomy device for stent under expansion. And the 0.9 laser would not cross. So in this case, here's the OCT. And as you can see it playing, you see 2 layers of underexpanded stent going proximal to distal. So very small lumens. Okay. So in this case, rotational atherectomy, because of the inability for the laser to cross, the 125 and 1.5 rotoburrs were utilized. Scoring balloon with the 3.0 by 10 millimeter angiosculpt with good expansion. This is the post atherectomy OCT, was showing better expansion after rota and pre-dilation. There's a proximal dissection. In this case, it is a dissection that is relatively deep, but not necessarily that lengthy. And this dissection could be left. So the rota result and laser atherectomy thereafter were utilized alone. A 3rd layer of stent was not placed, and this patient has not suffered from restenosis clinically since that procedure. Another patient, 95-year-old with chronic atrial fibrillation on warfarin, complained of dizziness and lightheadedness lasting about an hour, had a non-ST segment elevation MI at the outside hospital. Echo showed EF of 25%. And this is the final result from the prior picture. I'm sorry, the slides are out of order here. So this is the patient, the 95-year-old with very short left main and disease in the proximal LAD, as well as the circumflex and obtuse marginal branch here. So in this case, we elected to support the patient given advanced age, bifurcation disease that would need atherectomy, low ejection fraction presentation as non-ST segment elevation MI. Wired both lesions, pre-dilation. You see the circumflex there. Rotational atherectomy for the LAD. And that's after atherectomy. And then in this case, because the left main was so short, a complicated bifurcation stenting 2-stent strategy I don't think was necessary. And in fact, a modified kind of V-stenting technique I think was the best in this case. So given all of the things that we often talk about, Kulak stenting versus DK crush, I think frankly, in many cases, the anatomy should define what the strategy should be. And in this case, there really isn't frankly a left main to deal with. And the 2-stent strategy employed in this case, the V-stenting seemed to be appropriate. We left the disease at the circumflex so as not to have to contend with that OM bifurcation. And that's the LAD. Whenever removing a impella, I always cross over and take a picture. You still see continued bleeding at the removal site. So just cross with the wire, balloon inflation, tamponaded from the inside as well as external pressure. And after a few minutes of pressure, there was no longer any bleeding. And with that, I'll stop and take any questions. And thank you so much for inviting me. I really appreciate it.
Thank you very much for sparing your time on a working day, getting up at 5:30 a.m., all of you. And I'm really, really very thankful to all of you. And excellent talks. You covered everything that is possible to cover. You don't have, at the moment, FDA-approved drug-eluting balloon in America. There was one study published in European Heart Journal comparing the drug-eluting balloon versus stent in ISR in LCX, and 150 cases in each arm. And this was after the cutting balloon in both the setting to modify the plaque. And the result that the drug-eluting balloon is better than the stent. Like you said, that 2 layers of stent metal will be too much. You commented that since we don't have 2 layers of stent becomes too much. Any comment, Dr. Anirban Chaudhary, because you too have experience with the drug-eluting balloon?
Yes, I mean, in Europe, the approach has been if you have a stent failure and if you can prepare the vessel appropriately with regards to debulking, whichever mechanism you use, and if you're happy with the vessel preparation, then the preferred first technology is drug-eluting balloon. If that fails, then obviously you take it from there. In general, my understanding, the take on the results was, I can't talk specifically about circumflex ostium, but in general, for DES was still better than DEB. But especially if you already have a layer of metal and it's a bifurcation, you've already done the 2-stent bifurcation, I think it's very reasonable to use a DEB as the first choice.
Yeah, so but in short, we have a technology in India. Earlier, it was only plaquetexyl coated balloon, drug-eluting balloon. Now it is sirolimus coated, and it with a very different kind of technology. It's an Indian stent, and it's become very popular. It's called as Magic Touch. So it's become very popular. Do you have this Magic Touch balloon in DAB in UK?
Yes, it's been around for a few years. We had it on our show.
Yeah,
and
so
we might get it back for
Indian technology, because earlier they had a difficulty because 2 molecules are different. Paclitaxel is the fat soluble, and this is water soluble sirolimus. So it was difficult to coat on the balloon, but they have developed some technology in India, and it's an Indian product. So we have a little bit of idea on the result of this drug-eluting balloon, particularly in ISR, if you debulk in a proper way. So thank you very much. Very kind of you, all of you, to spare 4 hours, and that too early morning in the working day. So everything was... Please call 4000 or go to OR 16. I think they are calling you. So I think I'll let you go. Thank you very much. And I clap for all the speakers and live guests, operators. Thank you very much. We'll come back to you. And of course, you are invited when you know that I'm going to host 2022 CSI in December 8 to 11 in Chennai. So be my guest. Right away, I'm openly saying both of you have to be there. I'll send you the invitation. Block your dates. Thank you very much.
Thank you.
Thank you. Enjoy it thoroughly.
Dr. Ban, can I ask you one question?
Sure, anytime.
A couple of my colleagues had asked about, is there a link if they want to attend? Because I got a PDF which doesn't allow you to...
I think what I assume that the flyer that I posted in your WhatsApp has a link.
It's a PDF. So
it's a PDF, but it has a link. It says where the link is. Click here. Yeah. So you register and then you get a link.
Okay. Yeah. Okay. I will send you a message if they can't click? Because I saw that.
Absolutely. I understood your, I wanted to tell you this. I wanted to call you and inform you about all this. Because if you open the flyer, you'll say, click here for registration.
I saw that. I saw that.
Once you register, you automatically get a joining delegate link.
Okay.
To attend the program.
Okay.
That link is sent by Zoom.
I just didn't work.
It's auto working by Zoom.
So I guess I have to email this to myself.
Yes.
Because when I click it in my mobile.
I think there are two PDF. I'll send you the next one. And that will work. Let me send you the latest one. Just 1 minute, huh? Sorry for the inconvenience, if any.
Yep, I've got the one which seems to work.
Yeah. So then you have to register, and then automatically you get link.
Not a problem. I might have sent my friends the other link because you sent me two. I just thought they were the same.
Yeah. Sorry, I forgot to mention that the first one, the link is not activated.
Okay, not a problem at all. Thank you, and I'll see you tomorrow.
Definitely. Thank you very much. I appreciate your time deeply and your commitments to program. Okay. Thank you very much.
Okay.
Tomorrow we have Sharad Reddy, who's also a very good operator for CTO, and I'm sure he will enlighten us by doing a lamp like this.
Great.
Thank you.
You have a good evening. Take care. Bye-bye.
And of course, I thank all the participants, all the delegates for joining and sparing their time on working day. Thank you very much.
Thank you, sir. Thank you so much. Good night. Thank you so much.
Come tomorrow.
Okay,
Waiting
sir.
for you.
Thank you. Thank you so much. Good night, sir. Thank you.